I take this opportunity on behalf of Ophthalmology Society of West Bengal. I, Dr. Sudipta Mitro, as the Scientific Committee Chairperson, along with our coordinator, Dr. Arup Bhomik, welcome you all to this one of its unique type of session, walking hand in hand in diabetes and the eye. I hope in the next few hours, we are going to have an academic fiesta where we can discuss our we can share our experiences, discuss our dilemmas in treating patients with ocular diseases and comorbidities, mainly diabetes. As is customary for OSWB, so I request our Honorary Secretary, Dr. Aniruddha Maiti, to come up and felicitate our President, Dr. Arup Chakraborty, sir.
A very good morning. Welcome on behalf of OSWB. As Sudipta has already mentioned, this will be a different CME, a collaborative one. It's an honor to have diabetologist and nephrologist, the leading nephrologist and diabetologist of the city. And in our practice, every one of us do face a lot of difficulty sometimes in treating the patients when there is some systemic problem. So hopefully, end of the CME, we will have some consensus and we will be updated with the latest protocols and guidelines and also the newer and diabetic medicines and effects to the eye. So I think we have a very tight program. We should start on time. Dr. Vinayak Sinha yet to come. Once he comes, we will felicitate him. I think we need to start the first session. I would request our moderator, Dr. Saurav Sinha, to start the first session.
The panelists are from both the ophthalmologists and the physicians, diabetologists. I will request all the panelists to please come up in the front rows. Amongst the physicians, I think, don't see many of them. I'll call upon the ophthalmologists first. We have Dr. Debashish Boirage. Dr. Shubhashish Nag is not there. Dr. Vivek Datto again is not there. Dr. Shondip Mitra sir, I think is there. Yes. Dr. Shomdat sir is also not there. Dr. Maulay Sharkar is there. Dr. Arup Bhomik, Dr. Randa is not there. Dr. Vipin Rana, sir, yes, I saw him once. Okay. Yeah, Dr. Vipin Rana, Dr. Debashish Boiragi, Dr. Rudra Prasad Ghosh is not yet here, Dr. Shambhu Prasad Ghosh, Dr. Shibashish Dash, Dr. KK Rai has not yet reached, and Dr. Kolpita Dash. From the physicians, we have welcome Dr. Shubhashish Nag sir is here. Please come. Sir, please come up to the front rows. As the panelists, you can come to the first row. Sir, first row. And among the physicians, we'll be having Dr. Vinayak Sinha, Dr. Shomit Ghoshal, Dr. KK Gangopadhyay, Dr. Pratim Sengupta, and Dr. Amit De. You are the panelists for the whole of this academic fiesta in all the sessions. Thank you, and all over to Dr. Saurabh Sinha for the first session.
So it's a 5-minute talk followed by 2 minutes of discussion. We'll try and stick to that. Screening in diabetic patient and role of OCTA. I think it's a very interesting thing. OCTA, a lot of us are still not using, at least for diabetics. So I think Vedant is going to teach us on that. Vedant, go ahead, please.
For the chairpersons are different for different sessions. So in the first session, we have Dr. Obhijit Ghosh. Sir, can you please come up to the dais? Yes. Dr. Vinayak Sinha is not there, and Dr. Arup Chakraborty, sir, please come up to the...
Good morning, everyone. Thank you, OSWB and team, for giving me the opportunity. Let us look into diabetic screening and OCTA. Very typical of a patient who has been referred to the eye specialist multiple times, but somehow has refused to go or somehow has not found time to go to the eye specialist or the retina specialist. And that is why he comes up with this. And this is how a patient with a normal eye and a patient with a diabetic eye looks. And when we see such patients, we really feel sad that even after multiple advice by the diabetologist and the nephrologist, somehow they do not reach the retina specialist, and that is why the importance of diabetic screening in patients with diabetes, retina checkup for patients or for anyone after the age of 50 with any systemic conditions. This was what I found on the right eye, the left eye, and why this is important is because diabetic retinopathy in India, diabetic patients in India are on a rise. Around 65 million people have diabetes in India, and it is estimated that this will reach around 80 million people by the year 2030. And that is why the importance of diabetes, diabetic retinopathy, the retina screening, which is being emphasized today in this forum. The diabetic retinopathy prevalence estimated to be 5.7 million people with severe retinopathy by the year 2025. And that is why we say that when diabetes affects the eye, by the time the patient realizes it is too late. So every year, every 6 months, as per the regime, the diabetic screening should be followed. What are the risk factors for diabetic retinopathy? The duration over probably 10 years, 30 years increases the chances of diabetic retinopathy. Pregnancy, hypertension, nephropathy, hyperlipidemia, smoking, elevated HbA1c are the other factors. The detection of early diabetic retinopathy is important. Why? Because it is known to affect the eye and then the working period. So most of these diabetes now that we are seeing are in young individuals, 35, 40, 45, and this is the peak time of their life, of their work, and that is how it is getting misbalanced. Patients are unable to give productivity in their work, and the detection of diabetic retinopathy, early detection is important. The symptoms include blurred hazy vision, fluctuations, scotomas, black field, loss of vision in the center, and focusing the images. Other involvements include the eyelid, cornea, the lens, formation of early cataract, and that is why we see that patients with diabetes are also known to be affected with glaucoma. So just skipping the slides, mild, moderate, and severe diabetes, coming on to the main, why it is important for a patient with diabetes and how they are screened. We first look into the vision, the pressure, followed by examination of the pupils to understand if there is any presence of neovascular on the iris. Look into the cataractous changes, look into the fundus examination. If there are changes that we see on the fundus examination, we can follow it up with fundus photo, OCT, FFA or DFA as we call it, and other blood investigations. So the fundus photo involvement, the role of the FFA in diabetes is now decreased over a period of time because of the use of angiography, the dye, and that is why what we now have is the OCT angiography, which is basically a dye-less, a non-invasive diagnostic technique where we can picture the retinal images, the retinal vessels in a 3D model without giving injections, without the patient having to go through the process of injecting the dye. So it works on the principle of diffractive movement detection. And to look into some case examples, we can see how proliferative diabetic retinopathy was picked up on angiography, just a small NVE at a little away from the disc, and it was picked up on the OCT angiography. If we compare the disc in cases of DFA as compared to the OCT angiography, we can see how beautifully the NVE, which is seen here, appears on the OCT angiography clearly. So without giving injection, without giving dye, that the NVD has been picked up. In a patient with non-proliferative diabetic retinopathy, where the OCT shows that there is almost no change on the OCT, the patient still complained to have a worse vision in the right eye, and it was seen that the OCT angiography showed the changes in cases of enlarged FAZ. The ischemic diabetic retinopathy also shows a similar comparison of FFA with OCT angiography. The OCT angiography helps us to monitor the patients. So in patients with diabetic retinopathy, we can use this tool, and the angioplex matrix helps us to understand and identify how it over a period of time helps us to identify the changes. And if the patient is screened regularly, we can use this matrix to understand the diabetic retinopathy changes. It has also been proved in the studies, and this is what we look as an ophthalmologist into an individual examination of diabetic schedule. Thank you so much.
Thank you, Vedant. Yes. So I'll try and highlight 2 points from his talk. One, I'll ask the ophthalmologist here, if you have a walk-in patient for refraction, and you by the by ask for, are you a diabetic? Do you insist on that visit to dilate and see the retina? Or at least the patient refuses, I think you should put it on his prescription, advised retina checkup, patient wants it next visit. I think this is to sensitize the patient themselves that this is asked of them. All those things will happen, but I think we as ophthalmologists should put down their paper that they need a retina checkup to be done. Octa, lovely things that you've shown. How many of, I haven't been asking, I mean, I'm a retina person, right? Octa, I've not been asking in diabetic patients on routine basis. I think it's high time I start doing that. Especially the one you said, NPDR with a little poor vision, maybe just a 6/6 part or a 6/9. I would, what is the sensitivity of that? How good is that?
So in patients where clinically we are not able to pick up, sometimes it doesn't improve even after refraction, 6/9 part. Patient still complains that in the center there is some uneasiness, some difficulty, especially in reading. I think that is the best time when we have to look into OCTA. Non-invasive, 2 minutes, we can pick up the increase in the FAZ. I think that is the best solution.
Yeah, what we see for, sorry, I was going to say, foveal thinning, we just pass it off sometimes.
Excellent talk. Before I start, if you allow me, Sudipta is very fond of this kind of program, hand in hand, okay? So she started with husband and wife. Now it is ophthalmologist and, diabetologist. I am scared what is coming next. Because people are concerned about this woke culture all over the world. So I don't know what is coming. However, coming back to the subject, screening, excellent talk. 2 points I would like to, stress upon. First and foremost, patients come to us and diabetologists send us to detect whether there is diabetic retinopathy present or not. The first thing appears is the microaneurysms, okay? Now, the size of microaneurysm varies from 12 micron to 100 micron. And they become visible in ophthalmoscopic examination when they are at least 30 micron in size. And for, routine examination, when you are not very careful, you may miss even 30 micron, maybe 50 micron is visible to us. So it's beyond doubt that we are missing many, many diabetic patients, if we do not do this, OCTA. And second thing, it has been proved that sometimes the changes in the foveal avascular zone, they appears even before the clinical appearance of diabetic maculopathy. So even if there is no NPDR, if you do an OCTA, you can see the changes in the FSZ, and you can really detect that they are developing diabetic maculopathy. This is about detection. And second thing is follow-up. The excellent tool, you can measure the size of fuzz, the perimeter of fuzz, the vascular density, foveal capillary density. They are all given in numbers, both in superficial plexus and in deep plexus. So if you get the numbers, you don't have any to look at the picture and tell what is going on.
Absolutely right, sir. And that is why the angioplex metrics helps us to identify from one screen to the other.
Yeah, so we'll stop over here, but the take-home message is not that you do OCTA for all your patients. The take-home message you do OCT. If the vision is not matching up, then go for OCTA. So I think everybody started getting OCTA for everything, doesn't matter, we can do it. Go to the next talk. Thank you, Vedant, so much. Thank you, Shandip. Well illustrated. Thank you so much.
Yeah. Dr. Binayak Sinha has joined us. He's the president of the East Kolkata Doctors Group with whom we are collaborating. So I would request our president to felicitate Dr. Binayak Sinha.
I will request Dr. Sinha to say a few words. In fact, today's program was his brainchild, and it was not possible without his initiative.
For me, it's just a learning experience because really this is an area where I don't know anything about, and I've just come here to learn. I'm glad you've given me this opportunity. I might have some very silly questions, and I'm sure I'll be asking them as the program goes on. Thank you very much. Thank you.
Yeah, so thank you very much. I'll be speaking about OCT-based biomarkers in prognosis of diabetic macular edema. So briefly, there are quantitative parameters like central foveal thickness and macular volume, and there are qualitative parameters like DME morphology, drill, hyperreflective retinal foci, choroidal foci, and the status of external limiting membrane and the ellipsoid zone. So if you see the anatomical classification of DMO, it can be center involving or non-center involving. Now protocol V of DRCR has told us if very clearly that if the edema is non-center involving, we can observe. And patients, this is very important, patients with center involving DMO having a 6/9 vision can also be observed because it has been noted. If the vision worsens, if you start treatment, there is an excellent chance the vision will regain. Central subfield thickness is a very robust parameter, probably the most important parameter that we see. But remember, it varies between OCT platforms and varies between men and women. Now coming to the morphological classification of DMO, basically we can have a CME, combination of SRF and CME and ERM and tractional retinal detachment. So the presence of baseline SRF was associated with better visual gains. That means if a patient only presents with SRF, the chances of gaining vision is good. But the evidence is little conflicting. Some papers have shown us that CME has a better prognosis, but overall, maybe the subretinal fluid may have a better prognosis. Now coming to the qualitative parameters, they are the drill, ellipsoid zone, ELM, hyperreflective foci and hyperreflective choroidal foci. So what is disorganization of retina and inner layers? So see, this is the drill. If you see this side, you can see the layers of the retina, laminations, but in the center you're not able to see. So it means disorganizations, if there is disorganization of more than 50% or greater than 500 micron of the central around fovea, it is considered significant. And it is a very useful OCT biomarker for visual acuity assessment and capillary perfusion status. Now coming to the status of external limiting membrane. So this is an image where you can see in the center, you can see a large cyst, but you are not able to see the, you are not able to see, this is the ELM, it gets broken here. This is a normal patient where the ELM can be traced across the fovea. So ELM is a very interesting structure. It is a structure that connects photoreceptors inner segments to the apical process of molar cells, and basically it sort of acts as a barrier of movement of macromolecules. So whenever it is disrupted, there is flux of fluid into the retina, inner retina. So the length of disrupted ELM highly correlates with the visual acuity. Now coming to the status of ellipsoid zone. Now see, this is another patient of the DME. You can see in the center part the ellipsoid. This bright line is the ellipsoid zone. This cannot be seen here. This is how a ellipsoid zone is seen in normal patients. So ellipsoid zone is a zone of photoreceptors which is rich of mitochondria. That's why it is so white on OCT. It is a surrogate marker of photoreceptor integrity. So the length of disrupted ellipsoid zone is actually highly correlates with visual acuity. Hyperreflective retinal foci. So if you see sometimes within the retina, you can see small white dots which does not cause shadowing. These are hyperreflective retinal foci. These are small hyperreflective dots within the retina with reflectivity more than the RP. So HRF are predictive of worse visual acuity in DME, and HRF, if they are in the outer retina, they have the worst prognosis. They should not be confused with hard exudates. Hyperreflective choroidal foci is similar to hyperreflective retinal foci, but they are in the choroid. This was first described by our group in APJO, and it refers to inflammatory markers in the inner choroidal layers, and it has been seen that eyes with greater than 10 hyperreflective choroidal foci tend to have more poor visual acuity. To summarize, if you see the parameters, the central subfoveal thickness, if it is more, it is a very strong indicator that the patient is prognostically not going to do well. DME morphology, like whether the patient has a CME or SRF or CME with SRF, the evidence is really weak. Whether you don't know, sometimes you see a patient with CME with SRF, you give one injection and the entire retina flattens. So there is no clear-cut evidence. Drill, there is a very strong evidence that if the patient has a drill, it's a poor prognostic marker. ELM and EZ are highly predictive of final visual prognosis. HRF and SCF, there is lot of talk, lot of publications on this, but still the evidence is very weak whether you can really prognostic patient based on HRF or SCF. I would like to acknowledge help of my colleagues, Dr. Shirsha, Dr. Paulumi, and obviously Dr. Demallo for their help. And I take this opportunity to just to remind you, our Kolkata Retina Conclave by Shankar Netralaya Kolkata will be in Taj Tal Kutir on 17-18 May. Please keep your dates blocked. Thank you very much.
Thank you. Can we go back to your slides, please? I need to highlight a few things. So breakfast is available outside. Anybody, please go ahead with the seat. Right. So we'll stick to this. Demalo, what is your take on this particular slide?
So this is disorganization of the retinal inner layer. So you cannot see the retinal inner layer properly in the area highlighted. This is a strong indicator because people with this type of problem, having 50% of the area with this type of problem, will have less vision even after the treatment because the inner retina is completely disrupted, especially if it involves the fovea.
Right. So I think this is something we tend to miss every once. We are looking at more of cystic spaces, edema, subfoveal fluid. The HRF, they stand out and it comes to us immediately. This, I think, you'll see better if you go to the machine yourself, if possible, and see on the machine itself. This is something you'll pick up. Because this is a patient you need to be. Would you, one last, for treatment point of view, just to make it a little more interesting, patient with drill, would you start?
So drill, there is some evidence that some people with drill after treatment will respond. So you can start treatment with either anti-VEGF or a steroid implant. Sometimes there is some amount of patients in which the drill can be reversed, but not always.
Anybody, any of our panelists, anybody? One minute.
If you do OCT angiography in drill, you will get ischemia of the macula. It actually indicates the macular ischemia to some extent. So you have to go for OCTA, which can actually detect that.
So
and it actually
what you are saying is complement the first talk,
Yeah.
what Vivanta told us. Sir.
I've got a question for Rupak. Would you...
Second, Mane, I have a very silly question. So, what do we refer the patient to the ophthalmologist for? Do we refer them for an eye examination or for an OCT?
Eye examination.
And who gets an OCT?
That the person seeing the patient decides.
Okay, and if on examination there is no retinopathy, is there any indication for an OCT?
No.
Okay, thank you.
There are sub-parts to it, but to keep it generalized, I'll just stick to that. It's like, if I said to a patient is not a diabetic, you don't ask for an HbA1c. Right. But there are certain sub-parts to it.
Can I just answer Dr. Sinha's one question? I agree with Dr. Sinha completely.
With Sinha.
That clinically, if you want to treat a patient clinically, if the patient has no retinopathy, there is no role of OCT. But sometimes if you try to do OCT in a pre-retinopathy stage, because in diabetes there is an inner neuronal dysfunction, there is a layer called ganglion cell layer in the retina whose thickness can be reduced even before the retinopathy becomes clinically manifest. But that is in a routine day-to-day clinical practice, that is probably not very useful.
Rupak, would you choose a intravitreal steroid over anti-VEGF in those hyperreflective foci?
So, as I said, the evidence is really weak because now all of us have treated patients. People have recommended steroids when you see hyperreflective foci, but I believe all of the treating retina specialists know that even with lot of HRF, if you give anti-VEGF, they will flatten as well. So, the evidence is conflicting. But if it is pseudophakic, I will 100% go for a steroid.
Okay, two last statements, Sudipto and Shandip. Shandip, go ahead first.
Okay, first and foremost, I would like to object both of your statement that OCT angiography is reserved for cases only where diabetic retinopathy is visible.
I did not make that statement.
Okay, so I think if only one test is to be done, it is OCT angiography. Forget the cost. If the cost of OCTA and OCT are the same, what you will prefer? I will definitely prefer OCTA. So we are postponing OCTA just because of the cost factor.
Absolutely.
Now days are coming, when the diabetologists may directly send for OCT angiography, read the numbers. Don't even have to look at the picture. Read the numbers and tell this is having mild, moderate, severe diabetic retinopathy. So days are, be scared for that. No, and second thing, have you have a lot of experience. Have you developed any intuition that in cases of drill, you will start with anti-VEGF or steroid?
No, that's what I told you. You can either give anti-VEGF or steroid. It really does not matter. So around 80% of patients, if they have drill, the drill will not reverse. But 20% of patients after treatment, you can get back the OCT lamination back, the OCT structure back. So it does not really depend on anti-VEGF or steroid.
Sudipta, last statement. Very quick, very short, please.
Good morning. I think this is for Dr. Sinha. Sir, actually, one point I just wanted to highlight, even with very advanced retinopathy, diabetic retinopathy, patient can have absolutely normal vision and absolutely normal OCT. So that is one thing, because we can have a proliferative retinopathy which is in the periphery. So indirect examination of the fundus is probably the most important thing apart from investigations. They send the patient for eye checkup. Yes, so retina checkup is more important because it can have normal posterior retina with the abnormal periphery.
Yeah, I think it's...
So I think the message I'm going to take away is OCT will only be done if there is some kind of problem on examination.
On the central retina.
In the macula, in the center portion. Yeah.
Okay.
Thank you very much.
Dr. Sinha sir, unfortunately diabetes. Unfortunately, they having the degree of MD physician, they have not the few of the doctors have not the pain practice to refer the patient to the regularly to the ophthalmologist.
I think that is an area which we really need to work on, and I think we are slowly working on this, and I personally feel that there is an improvement. I think more people are...
Not all the MD physician not refer the patient.
I agree, but I think there is an improvement over the last decade or so.
Yes.
We'll move ahead, sir. We'll move ahead.
Many diabetic clinic now it is having OCT machine also.
Yeah.
Yes, and fundus photography.
We'll move ahead.
Yes.
We'll move ahead. 1 minute. We'll move ahead. Tulika, please.
Thank you, OSWB. Moving on to one of my pet peeves, the importance of HbA1c in the management of diabetic retinopathy. Glycosylated hemoglobin or HbA1c levels correlate well with diabetic control, the progress, and the outcome of diabetic retinopathy or DR. As far as we know, there is no study that evaluates the knowledge of ophthalmologists regarding the monitoring patterns of HbA1c in diabetic patients. Glycosylated hemoglobin is the gold standard and best long-term indicator for assessing glycemic control in diabetics over the past 2 to 3 months. The DCCT trial states that intensive therapy reduces the risks of development or progression of diabetic retinopathy. Glycemic control is a key modifiable risk factor. Both duration of diabetes and severity of hyperglycemia are the major risk factors for developing DR, and once diabetic retinopathy is present, glycemic control is more important in forecasting progression. The AAO preferred practice pattern guidelines state that an HbA1c of 7% or lower is the recommended target for glycemic control in most patients, although in selected patients there may be some benefit to setting a lower target of 6.5. Aims: to assess the awareness of ophthalmologists regarding HbA1c, current clinical practices regarding HbA1c estimation, relevance in managing diabetic retinopathy. Materials and methods, cross-sectional observational study, 900 printed questionnaires of 10 questions regarding the various aspects of HbA1c were circulated amongst ophthalmologists attending the All India Conference. 690 questionnaires were returned. This was the questionnaire that we devised. Nearly 61% of ophthalmologists correctly recommended HbA1c for all diabetics, although over 30% did so only for diabetic retinopathy patients. Nearly 3/4 rightly said that no special preparation is needed before HbA1c testing. 80% correctly said that HbA1c provides an average of plasma glucose control over 8 to 12 weeks. But only 41% of ophthalmologists rightly chose the normal range of HbA1c as 4 to 5.6%. Almost 42% correctly chose below 7% as the HbA1c target for good glycemic control. Over 97% agreed that the higher the HbA1c, the higher the risk of developing diabetic complications. Nearly 60% chose 3 months as the recommended frequency of HbA1c testing. Improving HbA1c by 1% in a diabetic cuts the microvascular complications by 25%. Nearly 78% rightly chose all the coexistent diseases that can affect HbA1c. 84% of ophthalmologists correctly chose the DCCT as a trial which recommended regular monitoring of HbA1c in diabetics. The values for the awareness of normal HbA1c levels amongst ophthalmologists were statistically significant by chi-square testing, where p is equal to 0.01 at 99%. Patient awareness of HbA1c is important, of course, but so also is the awareness and knowledge of ophthalmologists. To our knowledge, this is the first study that explores this aspect. So my take clinic message: endocrinologists and internists are requested to stress to diabetic patients the importance of regular, dilated eye examinations despite initial good vision, and also to collaborate with ophthalmologists as a multidisciplinary team in this potentially blinding battle. Ophthalmologists in India need to be more aware of HbA1c and utilizing its immense importance in managing diabetic patients who are at risk of losing their sight permanently. These are my references. Thank you.
I will straight away go to you, sir. This is actually your topic.
So I'll just briefly say thank you, Tuligadi. This is a beautiful presentation, and I think it's a study which was very required. We will have a detailed discussion on this in this session. The only thing that I will say is that this 6.57%, this is changing. You know, now there is a lot of discussion about, and I think one of the things that we see from a lot of ophthalmologists, and we are a little scared of this, is that strict glycemic control. Okay, which is the first line in most ophthalmology prescriptions. And that strict glycemic control is not going to be 6.5 and 7 anymore. It is what is suitable to an individual patient. And I think it is, say, you know, Dr. Ghosh was just telling me about his brother, 11% HbA1c, who's just had a surgery yesterday and worked beautifully. So there are people in whom we have to standardize and relax this thing to a large extent. I think as of now, I would say that 7 is the cutoff. No better than 7 is required.
Okay,
Thank you.
Just for the audience, because my wife is a physician, so ADA had some recommendations, and I think if you can just a little bit elaborate what you told us. So like you said, you said, I agree with that 8% in some patients is all right.
Yeah.
That's what you want to say again.
Yes.
You just insist on that.
So 7% is the cutoff. It's not 6.5 anymore. Avoidance of hypoglycemia is of paramount importance. Weight loss is of paramount importance. And say for somebody who's had a heart attack, you know, you don't want to have a glycemic control which will cause him to have hypoglycemia and worsen his heart. So, you know, 7.5, 8 is fine. And for people who are end of life, elderly, you know, people who have got chronic kidney disease on dialysis, even an 8.5, 9 is acceptable. So this is where we are going to.
This is
So
what I
you
wanted to
prefer
highlight
a
here.
slightly higher level, but which is steady, rather than the ups and downs?
Absolutely. I think that's very important.
So I think the take-home message was exactly what he said. The numbers are important for us. I'll ask you one more to what HbA1c. What is your recommendation? Should we as ophthalmologists write urine ACR on our prescriptions?
I think you should, because I think there's such a strong correlate with diabetic retinopathy. I think urine ACR is something that ophthalmologists should also be prescribed.
Every 6 months or every year?
Yearly.
Yearly. So I think it's the onus lies upon us to write on our prescriptions. HbA1c every 4 months. It should be 3. I accept that. I write 4 months, and urine ACR I write 6 because they do it in a year's time.
What do we take as the cutoff when we are operating?
It's coming in the next session, and you'll have a very detailed discussion.
We will discuss in the next session. Then
Thank you.
Let's move on.
Can I have Sudipta, please?
So a very good morning. I thank OSWB and the East Kolkata Doctors Group for this opportunity. So this is the topic on fitness and preoperatives for surgery and injections. Of late, I was not very sure about the data I'm going to present. So it's a preoperative evaluation essential, as you all know, that to reduce the surgical risk as well as to have a improve patient safety, helps determine the appropriate type of anesthesia based on the patient's condition. A systemic approach ensures better surgical outcomes, definitely, prevents intraoperative complications and reduces risk of postoperative endophthalmitis. But preoperative routine medical evaluation fails to show that this evaluation reduces systemic or ocular complications. I'll come into this. So COPD, poorly controlled hypertension, recent myocardial infarction, unstable angina, poorly controlled CCF, poorly controlled diabetes, as we all, I think probably we have a next session for this, needs proper evaluation. So ocular and systemic history, examination proper and suitable investigations, and especially for anesthesia checkup. So history, steroids and anticoagulants in already therapy, allergies, medications, comorbidities, ocular assessment, I think it's not very important in this part, but definitely in a comprehensive approach, this is a priority. And systemic assessment, claustrophobia, very important. A lot of times we face patients on table to have these complications. Cardiovascular, respiratory, genitourinary, UTI, I think we should not miss this. A lot of times we have these infections persistent in a normal patient. Parkinsonism, these are all difficulties in doing surgery as well as musculoskeletal abnormalities, kyphosis, scoliosis. This is a morbid obese patient. So these patients need some little more assistance before surgery, before you plan surgery, to see how we can cooperate, so to gain the confidence. This is a very elderly lady with kyphosis, was perfectly well after surgery, but this needs little more assistance compared to the investigations. So if this was a study by Airways Group, the task force guidelines to prevent intraocular infections, they have certain specific criteria for this, RBS to be less than 200, fasting sugar less than 140, these were the guidelines being formed, BP 160 by 95 less than this one, and anything, any deviation should have a physician or anesthetist clearance before you plan doing surgery. These are the guidelines for ocular surgeries as well as intravitreal injections. So this was a paper I saw published in 2000, which showed that this was the value of routine preoperative, and and it shows that routine medical testing before cataract surgery does not measurably increase the safety of the surgery. Very important, I think. So this, I went to few other studies also. This was a Cochrane review, and if you can see here that, your pointer, if you can see here, this is not very clear, but the patients who were not routinely investigated and the patients who were investigated, the odds ratio was not significant in the risk, in assessing the surgical risk or maybe the complications up to 2 months after the surgery. So that is one very important analysis. So investigations, the general principles, we have routine testing and the common preoperative test, what we normally do, CBC, coagulation profile, blood sugar, urine routine, ECG, chest X-ray. What is important in intravitreal injections part, that sometimes we need a nephrological opinion in patients of kidney diseases before planning or starting anti-VEGF therapy. So these are the topical, the different anesthesia we do, topical, local anesthesia and general anesthesia. The complications or the risk factors are mostly related to local and general anesthesia. Local anesthesia have some ocular importance as well as surgical importance. Risk factors, systemic risk, we have drugs hypersensitivity, very, very important. So a pre-op checkup of these hypersensitivity reactions, hypertension, diabetes and COPD already being discussed, and ophthalmic, as you all know, the risk of having a peribulbar block related complications in high myope or in case of trauma or rupture, where we need some more precautions. So this is one point I just wanted to highlight, because I think we must have faced few patients to have these complications of peribulbar lignocaine anesthesia or hyaluronidase anesthesia. So as intradermal skin test is very important. I think we all probably do before surgery. So this is a intradermal skin test, and this is the report of one patient where we have done all. To see, you can see a red mark here. This patient shows some hyaluronidase allergy in this patient. So we have to be very, very careful. And in those patients, probably we have to have a preservative-free lignocaine for block. This was a second cluster of strabismus cases after periocular anesthesia with hyaluronidase. So you have to keep in mind for these patients. Now, special consideration in high-risk patients, I think this will be discussed, but we have to keep in mind probably the anticoagulants part, the cardiac patients, very elderly patients, and ROP babies where we need pediatric anesthetists to be with us. This is one point I just wanted to probably not very related, but how you make a patient comfortable in during surgery is more important. This is a patient where the special consideration is high-risk patient. This was by Dr. Badrinath, the publication on canopy as well as head support. So anesthesia-related complications, nothing to be said. This is the case-based where you have a diabetic patient, how to manage. So to conclude, follow the evidence-based guidelines, American Academy as well as the ASA guidelines for preoperative evaluation, reduce the unnecessary testing, individualized patient care. I think that is very important. We consider systemic and ophthalmic risk factor assessment for these patients, select appropriate anesthesia for this, and a team coordination, collaboration with diabetologists, internalists, and the anesthesists for all this. And definitely one more very important thing, patient education and discuss all risk, and don't forget to take the consents on proper time. Thank you so much for your patient hearing.
Thank you so much, Sridhar. Please stay there. I'll make a quick request to you, that article that you showed, that AIS article.
Yes, yes.
You have the full article with you?
Yes, yes, yes.
Can you please share it with Dr. Aniruddha? Aniruddha, can you post it in all the OSWB groups tomorrow? I think that will be something very useful for all of us, just to read the whole article again.
This was actually for infection, but I think they have the...
We'll still read it and
yes,
get
yes.
some idea from
Yes,
that,
yes.
yeah, whatever it is. 2 points. I sort of don't agree with you. You said the odds ratio of doing a preoperative checkup and not. I think that's in the Western population. Lot of our patients, Shani Kartike, first time, oh, I'm diabetic. So I think it's, we cannot, those are very important articles. I'm not denying that.
Correct,
But in an Indian scenario, I think best is to get all tests done when you're doing a simple catheter, even under topical. Because if something goes wrong and he's a diabetic later on, or a low hemoglobin later on, any small complication, they will be ripped apart for not doing a checkup. I
That's
think
true.
sir will agree with me, Dr. Binayak, sir?
I totally agree with you. Totally agree with you. But I think let's wait for the next session.
Right, right. So anybody, any of my
Cataract surgery or any intraocular surgery. That's
this is why I said let's have it as a
yes.
group, all the WhatsApp groups tomorrow, so we'll all read up that articles. Can we close? We already 10 minutes overdue, so we'll close the session. Thank you all.
Hand over the memento to the speakers of the session. So I call upon Dr. Arup Chakraborty sir to first hand over the memento to Dr. Vidanksa. Dr. Obijit Ghosh sir to hand over memento to Dr. Rupak Roy. Dr. Vinayak Sinha sir to hand over memento to Dr. Tulika Ghoshal. So Rupak has left. So Dr. Rupak Roy has left. So Devmala will collect the memento. Can I have a round of applause for this? Thank you so much. And Dr. Tulika Ghoshal from Dr. Vinayak Sinha. Dr. Shudipto Dash. All three of you can hand over to Shudipto. Come on. And of course, Dr. Shorab Sinha. Sir, where are you? Dr. Shorab Sinha. All three of them can. Where is Dr. Shorab? Left? Left or he's. Oh, sir, please. Memento. Dr. Shorab Sinha. Chairpersons de tum de do. We have our seniors, Dr. Nag, Dr. Mohammad Yasin sir, Dr. Kajal Prasad Ghosh. The chairperson needs to be felicitated with the memento also. So all of you can join to just hand over the memento. Aniruddha, yeah, come. So please, memento to the chairpersons of this session. A round of applause for. Thank you, Jaraj. Vinayak, the join hands, yeah. You can let me be in the picture at least. Yeah. Dr. Vinayak Sinha. Can I have a loud round of applause? Without him, we couldn't have had this session. Thank you. Yes. The speakers, please join. I'm sorry, I'm taking 1 minute, maybe 30 seconds for this. Yeah, come. Shorabda, moderator to. Thank you. And I hand over to Dr. Sangeeta Roy and Dr. Debmalo Dash for the next session, which is a quiz session with delights. I am very sure it's going to be very, very interesting. Yes, of course, sweet.
Good
But
morning,
it's a
everyone.
diabetic.
So I'll just tell a few details. Everybody has a keypad in there, just hanged at the back of the chair. Please take it out. Everyone has one. It is tied up there. They have switched it on. All the keypads are on. And there are 4 options. I hope everybody has got there. Yeah. So there are 4 options, A, B, C, D. Whichever answer you think it's right, you just press that and press OK, which is there at the left-hand side corner, upper corner. And then you wait. Then when we ask the next question, you again press CE and then again you press the option. Okay. And there is a number at the back of every keypad. So that is your number. So here they will show the answer. How many people have answered that particular question, and whoever has answered first, that name also will show. Number. Then you can put up your hand when we call the number. So I would like to request our actual quiz master, because I'm nowhere near to a quiz, never attended a quiz and never been a quiz master. So Dr. Debmalo, please.
Hello and welcome. So we have 15 seconds time before the buzzer goes off. Everything put after that, your won't be counted. So we'll start the quiz, and quiz is nothing new for any of us. And this is a fun quiz, and we learn. And since we are ophthalmologists, so the questions will be a little tilted towards ophthalmology.
So for the first 12 questions, they have options. The last 2 questions, they don't have any options. Please put up your hand, whoever can figure out those answers, and you can tell the answers.
Involves a little bit of lateral thinking as well. This is the first question. So this famous ophthalmologist for the first time saw the diabetic changes in the eye. And in 1855, he published what he saw, and also which were he included in his fundus painting. Name him. There's a hint beside it. It's a near vision chart. We use that for near vision testing. This is a macular function test.
What is the other name for the near vision testing?
5,
Time starts.
4, 3, 2, 1.
Done. Can we have the answer? So answer B, 55%. So. আনসারটা আগে দেখো আগে আনসারটা দেখাতে দাও
It is C. 140. Who was 140?
114. Who was 114?
So near vision chart is known as Jager's chart. You should all know about it. You know Snellen chart. But whenever we check the near vision, that chart is known as Jager's chart.
Who is 140?
Fastest
এই তো
finger.
স্যার থার্ড টিপেছেন আপনি আপনার আগে টিপেছেন
140. 140.
স্যার আপনার আগে 140 টিপেছে ইয়েস হাই So he is 140. What is your name, sir? Huh? Second, okay, so who was second? Please keep that thing on. Who was second? The Dr. And Dr. Shondip Mitra third. A, B, C.
Let us see the questions also.
So when we go to, so chocolate for 140. হ্যাঁ সরিয়ে হাতে নিতে পারো So when we go to the next question, you press CE again. And then oh, why 1, 2, 3. 1, 2, 3, 4.
So let's go to the next
So
question.
press CE and then we will go to the next question. Is everybody ready? Yeah.
So the next question. The early treatment diabetic retinopathy study evaluated this drug along with argon laser photocoagulation as treatment for diabetic retinopathy. Name the drug. Your time starts now. So they compared this drug with laser.
Not exactly compared.
They tried.
Time's up.
Answer is
Answer, please.
aspirin. So they found out that aspirin has no role in vitreous hemorrhage, has nothing to do with diabetic retinopathy, but what it did was it prevented the extraocular complications associated with diabetic retinopathy. So aspirin, they said that can be given to prevent the other complications like CVA and CVS. Okay? 178.
Vedang. Second. 7. Who is 7? Dr. Nag.
Next. So this is for you, sir. So Frederick Banting and Das was awarded the 1923 Nobel Prize in Physiology of Medicine for the discovery of insulin. Name him. Exactly.
স্যার আপনি আনসার করুন হ্যাঁ করুন আর নাম্বারটা কেউ জানেন না তো আপনার
So 0
আনসার
is MacLeod. So Banting was furious when he came to know that MacLeod was getting the Nobel Prize. He shared his money with Best, and MacLeod shared his money with Collip, who worked on the purification of insulin. So it was MacLeod and not Best. And George Best was a footballer who died of alcoholism.
who is first
Who is first? First.
where is
Two.
the details
They are credited, but they didn't
show
give
us the
Nobel.
details of the last one don't go to the next question please
Who is 2?
129
129.
1 to 9. Gaurav.
Dr.
He's
Gaurav.
129. Gaurav sir.
Cornea guy.
And who is 13
13.
13 Dr. Parasaj.
So this is another question. Now you can see a particular part of cornea. I'm giving you the name. And a renal area, the nephron, whatever it is. And it shares its name with a particular physiologist. Name him. Start the timing. The same physician actually described both of them.
Bowman.
It is Bowman. Bowman's capsule, Bowman's membrane.
Bowman's membrane in cornea, that is the structure of cornea.
Number 124.
124.
Anujit.
Acha, Anujit
Anujit.
sir. And 134 is the second.
Sir.
Arup sir. Arup sir. 134.
How come Gaurav you missed out? Anyway, next. So all of the drugs can cause worsening of diabetic retinopathy. Causes worsening of diabetic retinopathy. Except. So this is for us to know that these are the drugs that can cause worsening of diabetic retinopathy. But we have to give sometimes. One of the things that we should know. And except. So the answer, anybody? Metformin. Because apart from metformin, almost all the drugs causes, answer to that.
Answer to देखिए दोगे.
All these drugs causes worsening of diabetic retinopathy, but insulin you have to.
Including insulin also.
So who got the highest number here? The first.
No, basically insulin, it is said that when a patient is
150.
started on insulin, there is a sudden decrease in all the parameters, and which immediately causes worsening of the diabetic retinopathy part. It is seen both in DCCT and all the UKPDs, all the trials, it has been seen that a very severe fall of blood sugars might also cause deterioration of the diabetic retinopathy.
Who got this right?
Number 50.
50.
50
Krishnakanto.
and 113.
113, sir.
So we are starting the next question. This ancient Indian physician, a contributor to Ayurveda, described people with polyuria. He noted that flies and ants are attracted to the urine from such patients and named the condition madhumeha, which means honey in urine. Name him. So, anybody knows the answer? Wrong. Charak. So apart from Hippocrates oath, we also take Charak oath. In AIMS, I think.
In AIMS, MBBS students, they take Charak oath. They don't take Hippocrates oath.
142.
142.
Who is 142?
Sir.
142. And
166.
second one is 166.
Oh, Shivashish.
I see.
For the next question.
Yeah. Or
Shivashish is the next.
So identify the painter. Identify the painter. You can get the hint in the painting itself.
On করা আছে স্যার এই নিচের এটাকে সরাতে হবে বলছি স্যার নামটা আমি বলছি
I can tell the name. It's Banting.
Frederick Banting.
It is Banting.
Frederick Banting.
So the base, MacLeod, Collip and Banting. You can get to see the hint in that. Actually, it's a lab photo. But he was a painter as well. Answer, Banting. Yeah, right. Yes. So who was the first person what's the fastest finger for us?
Can we have the answers? Can we have the
Who was the fastest finger? You can see the lab where he worked. He actually drew the lab. Next.
answer K first? 168.
168.
Yeah.
Second one is 19.
80.
19. No.
18.
You cannot take it.
Who is 18? Oh, 8. Sorry.
Achha, so we are coming to the next question. Pig is important. Not that we all are descendant of that, but pig is important. Why? Both in endocrinology as well as in ophthalmology. And you have 4 options. So one is xenotransplantation of cornea and insulin. Other is optic nerve regeneration and insulin. Retinal transplantation and newer insulin. And scleral transplantation and insulin. So all are insulin only. But what is the correct eye
The onus of the answer is on the ophthalmologist now.
So yeah, so person insulin and next, please.
Next slide, please. Eight. দুটো হবে না
Second 30.
স্যারকে একটা 30
30.
30 who is 30
Cornea.
cornea
So the
xenotransplantation
first corneal transplantation was done with pig's cornea back in 1833. It failed. No, Dr. Jam did with human cornea. This is in 1833. They did with pig, that failed actually. Now China is coming up with advanced corneal transplantation involving pig cornea. So they have done successfully 12 surgeries. So this.
now some direct questions so what is the prevalence of DR in India there are many studies done but we just want a range actually so anything which is they are মানে কাছাকাছি So this is around 16. Why I said there is a range because this was a study done in 2015, 2015 or around that. It was done in AIMS and there the prevalence was found to be around 17%. There was a study also done in Shankar Nethralaya where the range was found to be around 21% and which was published after this. $163.
163.
Ma'am.
163. We'll start the next question.
Okay. So this particular study compares the incidence of cardiovascular risk with diabetes control. Which is the particular study? Any direct questions, sir? So it was a CORD trial. In fact, the two groups were compared where intensive control and normal control was compared. Intensive was HbA1c around 6.5 and this normal control was around 7 to 7.5. It was seen that the cardiovascular risk and risk of mortality and morbidity was more in patients in which the HbA1c was kept at 6.5. Even that that arm was stopped after a few years. 29.
29.
And abar 8.
Presentation. Now, this is the next question.
What is the AIS guidelines for sugars in for intraocular surgeries? We all know we take less than 200 random blood sugar.
I think number 8 had actually told that in the presentation, so he will be excluded this time.
স্যার আপনার এটা চেক করব আমি এবার
So the answer is
yes this is taken directly from the AIOS site FBS they have said it should be less than 140 milligram per deciliter আমি আপনাকে WhatsApp করছি
and this was told by Dr. Sudipta Dasif
185.
185
7.
Sir,
7 knocks.
আর 7 এই তো স্যার
হয়ে গেছে হ্যাঁ হয়ে গেছে দিয়েছি হ্যাঁ দেয়া হয়ে গেছে
So This is for everyone. Actually, we thought more of endocrinologists will be here. When to refer the patient of type 1 diabetic patient for screening?
According to studies, actually, if you get one, please send it immediately. They are already late. So, if you have been to a quiz contest, no.
So commonly, what we do? What we
No,
do?
see, quiz is not a fighting arena. Here, the quiz master is always right. You are always right. We are always right. But have you pressed?
Answer, please.
So, can you get me the
Answer, please.
Next.
Great. So type 2 diabetes has to be referred early, immediately.
Who is the winner?
Who is the winner? Conta
95.
95. K9, sir.
Second one is
95.
108.
13 type of these.
Second one is 108.
108. Hey, ma'am.
Acha.
Next question, please.
A very big thank you to both of them and the Ajanta Pharma, especially Mr. Shotyajit, for arranging all these keypads and the chocolates. Can I have a round of applause for all three of them? And to hand over the mementos to Dr. Shangita Roy and Dr. Debmalu Dash. Debmalu has prepared these beautiful questions, always sixes. And also Sangeeta helped her in it. So, okay, Dr. Shodhi Mitra, please come ahead. Please. Sir, time nahi, sir. Please, Ashok. Thank you so much. Your questions were really enjoyable. Thank you. Hey, please, dujone alada আছে। আয় না। চলে যাও। যাও পাশে যা। তুই কাছে যা, ছবিটার কাছে যা। Thank you. Now we have Dr. Gaurav Chauhan. Dr. Gaurav, please. A new child in the block for dry eye. Dr. Gaurav Chauhan.
Good morning, everyone. So today I'll be talking about a new drug, lifitegrast, in the management of dry eye. We know that dry eye is almost affecting 30% of the world population, and it will be affecting around 50% of the Indian urban population by 2030. The 25% of the patients who come to our clinic are generally having the symptoms of dry eye disease, which include ocular discomfort, reduced visual function and quality of life, as well as DD also affect the outcomes of the ophthalmic surgeries. The risk factors are multifold, like demographic, modifiable lifestyle, like digital use, environmental factors, ocular and systemic. Classification, dry eye is generally divided into three types: aqueous tear deficiency, evaporative type, and mixed. Aqueous tear deficiency can be due to Neuen-Jogren or Jogren syndrome. The pathophysiology, the key factor is the hypertear, hyperosmolarity, which can be due to decreased tear production or increased evaporation, which lead to ocular surface damage and inflammation, and this inflammation again attracts T cells and other inflammatory cytokines, which increase the inflammation, and a vicious cycle is set up. So the role of T cell in this whole pathophysiology is the antigen presenting cell first migrate to the lymph node, and they activate the T cell. These T cell then travel through the blood vessel to the conjunctiva and are activated there, and then the inflammation goes on. So the treatment goal are generally lifestyle modification, tear supplementation and pharmacological intervention to reduce the inflammation. The other treatment in severe cases are specialist contact lenses like scleral lenses. So the limitations of these management include artificial tears just address the tear osmolarity and not work on underlying inflammatory pathophysiology. However, the corticosteroid drugs have their own side effects, and cyclosporin A has a delayed onset. So the unmet need for these therapy are rapid onset of progression and reducing uh, inflammation with good tolerability and long-term safety. So let's see how lifitegrast can be helpful in this. It is a FDA approved drug and has been designed to block LFA1 and ICAM binding, preventing the T cell adhesion and inflammation. So this is the molecular structure of lifitegrast. Coming on to the pathophysiology, the T cell mediated inflammatory pathway, which is very important in the in dry eye, is mediated by LFA1 and ICAM1 receptors, and lifitegrast competitively antagonizes these receptors, hence reducing the cytokine release and disrupts immune synapses and reduces the inflammation. It is highly soluble in aqueous media, have a rapid absorption into the ocular tissue and rapid clearance from the systemic circulation. So let's see some clinical evidence of lifitegrast. First, the OPUS trial. It was a phase 3 trial, a multicentric randomized control trial with a steady population of 588. It showed that lifitegrast showed a Sharma staining of the inferior cornea at 14 days, and these effects were carried on till the end of the follow-up. There was also Lisa mean green score decrease at day 14, and these results were seen throughout the study period. The other two things were ocular discomfort and eye dryness scores. These also showed improvement at significant improvement at day 84. So there were no unexpected ocular or serious adverse effects. Hence, the OPUS 1 trial showed the efficacy of lifitegrast clinically, reducing clinical as well as symptomatic effect of the dry eye. In OPUS 2, the similar results were seen, and it showed the eye discomfort to be significantly less as compared to placebo. In OPUS 3 trial, it was a safety trial, and lifitegrast showed no serious ocular treatment emergent adverse effects, and the most ocular and non-ocular side effects were moderate in severity, and hence the OPUS trials confirm the long-term use of lifitegrast. Koluru et al. Did a study comparing the cyclosporin and lifitegrast, and they showed both osmolarity and the Sharma staining to be better in lifitegrast. In Nicholas et al. Did a pooled analysis of 5 RCT and with an extended follow-up period up to 1 year. They showed that the adverse effects were mild to moderate, and there were no serious ocular side effects. The drop discomfort was more in lifitegrast, but it significantly decreases after 3 minutes. Hence, the lifitegrast 5% showed to be safe, well tolerated for treating dry eyes over a long term with unexpected adverse events. So to summarize, the lifitegrast help in decreasing the T-mediated inflammation, and hence and has a proven clinical efficacy and safety profile. I thank you all for.
Thank you, Gaurav. In today's world, it's a burning issue, dry eye, especially with digital work, and with comorbidities on which we are talking about with diabetes, we have inflammatory dry eye. So I hope, although I myself personally do not have much experience with it, I hope this drug is going to be a promise. What do you think? Have you got some experience with it?
Not yet. It is a new drug, but the trials have shown promising effects on the, inflammatory dry eyes.
Okay, so in time we'll come to know how it reacts. Thank you so much. This we have Ajunta launching this particular drug here. So just give me 1 minute.
So we will start the session 2, diabetic retinopathy and nephropathy. May I call the chairperson on the dais, Dr. Devdash Mukherjee and Dr. Kajal Prasad Ghosh and Dr. Pushpita Shah. Madam, on the dais.
Inflammation stuff, here's a deal. Vivanta's here to help you heal. With lymphatic grass, it's clear to see. This is calm, your eyes feel free. Vivanta clears the way. Goodbye to dry eyes, hello today. Lymphatic grass magic, a soothing surprise. For comfort and clarity in your eyes. T-cells is as Vivanta works. Relief from irritation and quirks. Dry eyes vanish, peace remains. No more discomfort, no more strain. Vivanta clears the way. Goodbye to dry eyes, hello today. Lymphatic grass magic, a soothing surprise. For comfort and clarity in your eyes.
Just before we start the next session, can I request our chairperson to just come over and hand over the memento to Gaurav? Thank you.
So we start the second session with the first talk, the role of FFA and its correlation to nephropathy. We will be missing Dr. Pratim Shemgupta, who was supposed to talk on anti-VEGF and eye in a nephrologist perspective. His flight got delayed. Nevertheless, we will have a discussion on this topic. Krishnendu, please start.
Good morning. Good morning, everybody. So, in brief, I will be discussing on FFA and nephropathy. It's a correlation. First, about the history of FFA. It is the fluorescent dye first invented in 1882. This being inspired by Devmallo, so I have written some history. And FFA, the fundus fluorescent angiography, first discovered in 1961 in the Indiana University, and it is used in our day-to-day practice to image the retina and choroid. So actually we inject in the antecubital vein and then take on pictures to get the fundus picture of FFA. Actually, why we need the FFA? That is important. The sodium fluorescent dye is non-toxic, is safe and highly protein bound. The non-protein bound, that is the 20%, is we utilize for the angiography purpose. And there are some side effects, that is nausea, vomiting is most common side effect. Rarely it can cause anaphylactic reaction and bronchospasm. So indication is mostly the retinal vascular disorder, that is diabetes, retinal vein occlusion, unexplained vision loss, central serous chorioretinopathy and pachychoroid spectrum. So what we do to see what we see in FFA, we see if there is any focal or diffuse maculopathy. To evaluate the unexplained vision loss, that is the macular ischemia, peripheral neovasculation and non-perfusion in the periphery, and then to identify the clinically obscure retinal neovasculation which is not detectable by clinical examination. This is a case scenario. If you can see, there is a hardly an edema in OCT, patient is diabetic, vision is very less, counting finger 3 meter. And you can see in FFA, there is a gross non-perfusion and macular ischemia. That is the cause of vision loss of this patient. This is another example, case scenario 2. There is a lot of neovasculation elsewhere, undetected by fundus examination. So this patient needs laser. Another case scenario 3, there is a neovasculation at the periphery along with the non-perfusion at the periphery. So patient needs laser therapy. See, this is a case scenario 4, lot of laser has been done, but there is an existing neovasculation at the periphery which has to be lasered again. So this patient need fill-in laser. So does FFA pose any risk in nephropathy patient? Let us see the evidences. So this is the evidence number 1. This is a meta-analysis which shows there is among the patient which undergoes the fluorescent angiography, the dye does not cause any increased risk of contrast-induced nephropathy, that is CIN. This is the second evidence. Its recommendation is the patient who is existing diabetic nephropathy is safe to undergo fluorescent angiography. The third evidence. This evidence shows the grades of CKD patient. There's a grade 1 to grade 5, different parameters. They have measured the pre-injection GFR and the post-injection GFR, and those are not statistically significant. So they concluded no significant effect of renal function after performing FFA. This is being done 48 hours of performing FFA. So if you're still not convinced, you can opt for OCT angiography if you think the patient is at risk. So to conclude, FFA in diabetic retinopathy is safe and it is also informative. Some relative contraindication is patient awaiting for dialysis and the end-stage renal disease. FFA is safe even in dialytic patient who undergoes dialysis, and little safer option is OCT angiography if you think. Thank you for your patience hearing.
Thank you, Krishnendu. So practically now, I think overall the use of DFA has come down, and obviously with the Octa, it has even further down. So what is your D-indication for the DFA in DME, in cases of DME?
This is the picture. This is being replaced by Octa itself. So this is the one on the indication where we can do FFA if you don't have Octa. The macular ischemia. To see the macular ischemia, and even if the patient underwent laser, to see the peripheral CNP area, the still existing neovascularization is still there.
Macular ischemia can be still picked up with the Octa, but for detecting the focal leakage and where you are planning to do a laser, I think still the DFA
is still valuable.
Good. I think that is. Now we are discussing about the DME part and diabetic retinopathy. So, any particular level like the kidney profile you will look after before doing advising a DFA? Means what is your cutoff mark? We don't have Dr. Pratim, so I would have asked this question to
If the patient is
Dr.
having eGFR, that is a GFR less than 15, that is a stage 5, then we like to take opinion before the patient are doing FFA from the nephrologist.
What routine test are you going to recommend before doing a DFA?
eGFR.
Only?
If the patient is severe nephropathic awaiting for dialysis. If the patient is on dialysis, there is no problem.
Any particular level of the creatine you need to see?
Creatinine doesn't have any role. That is our myth. We don't consider creatinine at all because the eGFR does not reflect the creatinine. It is the eGFR which is most important parameter that we never test in our day-to-day practice. We always write serum creatine, but that doesn't reflect the actual kidney status. The GFR is the actual kidney status.
I have a question, Aniruddha. First of all, the pictures in Octa that we have seen so far is to do with the central retina. I am not sure. I mean, do you have the peripheral evaluation as well? Because we have never seen any Octa showing, the peripheral neovascularization. Or do they show that in Octa or do they not?
It's mainly for the central part. Peripheral,
So
it's difficult to pick
still
up.
has its advantage, as you were saying. But you never show. We've never seen.
No, that actually you have to tell your the technician to take peripheral images. But in presence of cataract, it is very difficult to interpret. But we can pick up NBE, CNP areas in the peripheral retina.
But it's difficult for us to do this peripheral area, because we don't always see the periphery. So do you do that?
Yeah, we do it. No, we do it routinely.
As a routine.
Yeah. For diabetic patients, where we are suspecting proliferative diabetic retinopathy, we do it open.
That's what he said, but I just wanted to know whether you do the periphery, because most of the screenings are done with the central thing. Those who see that, they don't see the periphery. So to say, look at the periphery, very often it's not done.
We can image peripheral retina with Octa.
You do it as a routine.
Yes, for diabetic patients.
But if the FAZ is distorted, if the FAZ is not within the limits, it gives us an indication that the peripheral retina is not well.
Yeah.
So central imaging first, followed by the peripheral imaging.
Vedang, how much periphery can we go? Do we have to use a special program for that, or it's a routine? It can be available in routine Octa. arcade and little beyond. Okay. But still, if you suspect neovascularization, you are going for an DFA?
No, actually my indication is if we have cataract where we cannot image.
You cannot pick up the
findings on OCT angiography, I go for DFA.
So gradually FFA is being replaced by OCTA.
Okay, thank you, Krishnendu. So we come to the next topic, newer medication in retinal diseases that physicians need to know, but unfortunately we don't have much physicians in that room. Okay, Amit has just entered. Welcome, Amit.
So thank you OSWB for this kind opportunity. I'll be basically speaking on newer medications in retinal diseases with respect to diabetic macular edema in particular and retinal disease, vascular diseases in general. So this is basically for the physicians and not so much for the ophthalmologists who know all about this. So this is a journey of the treatment development of diabetic macular edema. So if you look at the last century, then it was laser photocoagulation as was the primary treatment for diabetic retinopathy and diabetic macular edema. And the goal was to prevent blindness. But the current goal is to improve vision, and you have intravitreal anti-VEGF therapy such as ranibizumab, aflibercept, brolucizumab, bevacizumab, which is off-label, and also corticosteroids and certain other drugs we'll be talking about. Now the difference came about with the advent of the OCT, optical coherence tomography. Previously we were looking at the fundus photo or the angiography for that matter, but once OCT came along, we started looking at the retina in a histological perspective, and we realized that all these diseases, wet AMD, diabetic retinopathy and macular edema, BRVO or CRVO, actually have one thing in common, that is fluid. And these fluids can be of different types, and this fluid is in turn dictated by the increase of the VEGF levels. And therein came the anti-VEGF, started the anti-VEGF era in around 2004. And it was this gentleman, Professor Philip Rosenfeld, who is one of our teachers, who actually started this journey in a big way. And he initially used bevacizumab, and of course you have other anti-VEGFs. So anti-VEGF therapy has been transformational in reducing blindness due to retinal vascular disease, and it started off with pegaptanib, which was very specific for VEGF 165 only. And then of course, like I mentioned, bevacizumab was used intravitreally by Professor Philip Rosenfeld, and then you have ranibizumab, aflibercept, brolucizumab and faricimab. But probably the game changer was ranibizumab, with consistent 12-month visual gains in diseases such as neovascular AMD, DME, CRVO, BRVO, myopic CNVM, even in ROP. So there's no doubting ranibizumab. And initially it was launched as Lucentis, and then came the India-specific Eccentrics. And of course you have biosimilars, Razumab, Renize, Osiva, Visumab, Renizurel. This is just an indicative list which the physicians might find in the prescriptions. However, DME is a long-term disease requiring repeated treatments to maintain vision outcomes, and ranibizumab basically works for around 4 to 6 weeks. So all eyes also do not respond in a similar fashion, and you have a lot of eyes who are poor responders or non-responders. So therein people started thinking about corticosteroids and fluocinolone acetonide. And so you have Ozurdex, which is dexamethasone, which is available in India. Fluocinolone acetonide is not that available in India. However, there are issues with cataract formation and raised IOP, which is something that one needs to think of. So it was back to the drawing board, and people realized that besides VEGF, which was acting on the VEGF receptors, there was also placental growth factor, which was also acting on the VEGF receptors. And out of this research came aflibercept, because it was noticed that poor responders to ranibizumab have elevated levels of placental growth factor, giving rise to edema and all the other retinal vascular diseases. So aflibercept could block this placental growth factor as well as VEGF A and B. So pan-VEGF blockade with placental growth factor blockade, as opposed to ranibizumab, which only blocks VEGF A. So you had better visual acuity gains with aflibercept, and this was noticed by studies such as Protocol T, and this was right up to 2 years. There was some difference here between aflibercept and ranibizumab, and of course with bevacizumab there was a lot of difference. But as time went on, although aflibercept was mentioned as the drug of choice, especially with patients with poorer visual acuity, what was noted is that with time all these drugs actually had some amount of decrease in vision, even if they were treated as per the protocol. So the available anti-VEGF agents were not really perfect, and people started looking for better efficacy and durability of treatment. And out of this research came brolucizumab, which is a single chain fragment antibody, which is probably one of the first to be used in the human body. And this is of course brolucizumab, the India specific marketing name, Pegenex. And what Pegenex or brolucizumab has an advantage, where it has an advantage, is that visual acuity wise it is similar to aflibercept. However, it's better when it comes to drying with brolucizumab. Of course, there are some inflammatory issues that have been noted with brolucizumab. And then, moving on with the research, it was realized that DME is multifactorial. I'll just take 1 minute. So basically, you have stability of the retinal vessels in question, and here Ang1 type 2 signaling actually becomes important. And if there is excess of Ang2 which occurs in disease and VEGF-A, what happens is that there is breakdown of the endothelial cells and the pericytes, and we will you have a faricimab coming out of this. So similar visual acuity gains as compared to faricimab and as compared to aflibercept and others, but you have a longer time which actually you can stop injecting or give a longer break. But you have newer agents coming up, such as the Susvimo, which is an implantable sort of a intraocular implant, and you have can do a office refill of the drug. So any other pathways left? So I'll just mention the names. OPT 302 for lack of time, VEGF-C and VEGF-D pathways are targeted, and you have plasma kallikrein inhibitors which are also coming. And you have to eliminate senescent cells to actually stop this cascade, and this is also becoming going to become a reality. And also you have these vectors which can produce VEGF within anti-VEGF within the eye. So thank you for your kind attention.
Thank you, Devdulalda. You have mentioned all the medications, all the anti-VEGF molecules, and as well as the steroid. So when a DME patient comes to you, how do you decide what to start with?
Well, for starters, if it's a young patient, it's a phakic patient, then I look at anti-VEGFs only.
What anti-VEGF? Because we have a lot of anti-VEGF, lot of biosimilars of anti-VEGF molecules.
So, if you go by the Asia guidelines or the European guidelines, then of course, aflibercept is still probably the gold standard if it comes to decrease of vision less than 6/12 and all. So that is number one. Number two is, if you have patients who cannot afford, then of course you go for biosimilars. Otherwise, it's more or less the patient's choice. And of course, if you are thinking of the newer anti-VEGF the patient is willing to use with the increased pricing, then of course you can go for the faricimab, which is the newer one.
So do you follow this concept of what you have proposed in the transform trial, that start with an aflibercept or the higher molecule and then maintenance with a biosimilar?
Absolutely, because it's not me following the transform trial, it is the patient making me follow the transform trial. So because the patients actually opt, and that is how we got the data, like so it's not me, it's them teaching me a lot.
And Devdulalda, one last question. In a patient with diabetic retinal nephropathy, the eGFR is less than 20, so which drug you want to give to the DME patient?
Well, actually, then it's then it's better to go with steroids, I think. And of course, you have to take a permission of a nephrologist and then go ahead. So that is what I do. I send the patient to the nephrologist or the physician for a clearance for anti-VEGF. With DME, it is easier because you can get away with steroids. But with NAMD or maybe CRVO, which is doing bad, ischemic CRVO, then you are at a loss. You cannot really use steroids there. So that is where actually the problem is, not so much with DME.
Thank you, Devdulalda. So our next talk is by Dr. Aniruddha Maiti, telling about the enhancing diabetic retinopathy management, affordable and effective treatment with biosimilars in ophthalmology.
Thank you, Krishnendu. Well, already mentioned by Debdulalda, it's almost all the anti-VEGFs. So my talk will be specifically with the biosimilars which we are using very frequently nowadays. We are all aware of the diabetic retinopathy burden, global burden, and regarding the current treatment, yes, anti-VEGF has become the gold standard, which was once upon a time laser. Now it has been used as an adjunct, and sometimes a steroid we need to use where anti-VEGF we cannot use. Challenges, yes, the cost, availability, and the patient compliance is an issue. And if you see the poor compliance to anti-VEGF therapy, the major concern is non-affordability. And you can see all, whether it is a DME, AMD, RVO, all are driven by the anti-VEGF therapy. So I think the most important part, that the burden of the retinal disease, which is quite a huge on India, that is almost 1.1 crore, and most of us cannot afford it. Government scheme doesn't support the, only a few can afford through the government scheme. And the greatest advantage of the biosimilars is it can reduce the cost by 25 to 50% by using biosimilar instead of the parent molecule. Now you need to see how efficacious is this biosimilar with the parent molecule and how safe it is. And coming to this, Razumab, this was the first biosimilar in ophthalmology all over the world, and this was launched in 2015. And if you see the definition of biosimilar by the US FDA guidelines, it is a highly similar to the reference product, notwithstanding minor differences in clinically inactive component. According to DCGI guidelines on the biosimilars, it is highly similar to the reference product, no clinically meaningful difference in terms of safety, purity, and potency. So with lot of studies been conducted, Razumab being the world's first ophthalmic biosimilar, it has been cleared by DCGI in 6 indications. That is almost all indications where you use the routine anti-VEGF. So the biosimilar Razumab can be used. Now, while selecting the right biosimilar, it is very important in this current scenario, because every 2 months we are getting a new biosimilar. So we need to look after whether this biosimilar is safe. We need to see whether this molecule has undergone studies. We have seen few molecules which has been launched in the market, and within 2-3 months it has been withdrawn due to adverse effects. So we need to be very careful about the safety issues, and obviously the efficacy part we need to take care. So if we compare this biosimilar Razumab with Lucentis, head-to-head comparison of the Razumab and Lucentis biosimilarity assessment, it has been seen there is no difference in terms of size variants. Potency was observed between the two size exclusion chromatography, capillary electrophoresis. There is a lot of things that is not our domain, but we need to see whether it is similar to the parent molecule and whether it is safe in the clinical practice, which I think it has passed through, and it has been, we have been using for the last 10 years. And most of the biosimilar molecules, it's not been indicated other than wet AMD and DME. And there is almost 17 publications with this new molecule. This is the DCGI approval certificate. And this is the clinical evidence supporting the use of the first biosimilar, that is Razumab. And luckily I was also associated with few studies like ASSET studies and the TRANSFORM study. And it actually didn't see, not only see the efficacy part, the safety part was also a concern. It was seen that it is almost similar to the parent molecule. Nowadays, they have launched newly the PFS, which is also, it is more safe than the vial, syringe and vial system. And so we can say that with lot of studies, with our real life experience for the last 10 years, it is quite efficacious, and it is quite safe. But all said and done, we need to, after all, this biosimilar molecule varies from batch to batch. We need to be very careful, need to have a very stringent follow-up, because recently also there were some issues with the biosimilar molecule. So we need to see the patient the next day, 2 weeks later, to see whether there is any reaction or not, and need to notify if there is any reaction. So experience, yes, I will just mention one case. This was diabetic macular edema. You can see with the 660, with the loading days of 4 injection, it improved to 624. And after the 6th injection, it is 612. There are other indications. We have been using this new biosimilar molecules with a favorable result, and there was no safety concern. So the take home is the Razumab molecule is quite safe. It has been found to work in the diverse retinal conditions and mostly showed effectiveness with no evidence of severe intraocular inflammation and safety concerns. Thank you.
Thank you, Aniruddha. So we have lot of biosimilars with us. So which one you like to prefer?
Now that's what I was mentioning. It is always better. Let's not jump into a new biosimilar just because it was given free. I think we need to see what is the effect, what is the trial been done. At least before getting DCGA approval, they have to do some trials, and it is better wait and see and then use it.
And I have heard that biosimilar of Aflibercept is going to come also into the market. So if it does come, then which one you like to prefer, the ranibizumab biosimilar or Aflibercept?
We are yet to know what is the effectivity of the biosimilar Aflibercept. We all know the Aflibercept is a very nice molecule, but we need to see whether the biosimilar molecule also is equally effective. If it is equally effective and the cost comes down to similar to the biosimilar of ranibizumab, I think the biosimilar of Aflibercept we will be using more and more.
Thank you, thank you. Yes, one question from Chandra Mitra.
This is a question both to you and Devdulal actually. When do you feel the time is ripe to shift from anti-VEGF to steroid?
In my practice, I at least start with the anti-VEGF. I will give at least 2 injections before concluding that there is a suboptimal response, and then shift to either a long-acting anti-VEGF or to a steroid, depending on the. At least I will give 2 injections. Ideally 3. It has been used. I have not personally used, but it has been used.
Yeah, there is a study. That biosimilar can be used in ROP patient safely. There is a study published from West Bengal only.
I think Somnath Chakraborty has published the use of Razumab in ROP patients. Right, Vishnu? Okay. That was the biosimilar of.
Gujarat, sir. Dr. Vipul Chitravanshi has published that.
There are studies which they are using for. I think Razumab is also India. It has got the DCGI approval for use in ROP. Yes. Yeah, that's what I know. Long-acting anti-VEGFs are faricimab is the latest molecule. It has been seen in the trials as well as in the clinical in a real life scenario that it stays for 2 to 3 months, and as well as brolucizumab. Brolucizumab also stays for a longer time compared to the conventional anti-VEGF what we were using like Razumab, ranibizumab.
Okay. With that, we come to to the end of this session. And before we go to the next most interesting session, the diabetologists speak. I would request our chairpersons to hand over memento to the speakers. So, Dr. Pushpita Shah and Dr. Kajal Prasad Ghosh, please come ahead to present memento to Dr. Krishnendu Nondi, Dr. Devdulal Chakraborty, Dr. Aniruddha Maiti. Please, can I have the mementos? Devdulal. Can I please have a round of applause, and please come over for a group photo as well. The panelists are panelists for the whole of the session. So, please come. Aniruddha Maiti, please. And just please don't go have a group picture of the session. Have a group photo.
সুদীপ্তার পাশে দাঁড়াই এরকম কোঅর্ডিনেটর করেছে
Thank you, all of you. For the next session, I hand over to Dr. Binayak Sinha, who is the moderator of the session. And we have Dr. Pushpita Shahu and Dr. Obhijit Ghosh as the chairpersons. Please come over to the dais.
Good morning, everybody. Let's start this session. We will not waste any more time. Thank you, Babulalda, for getting this session in place. It was just a chance meeting with you and just a little discussion, and you encouraged to get this program in place. So thank you very much. We have three brilliant speakers who are going to be telling you the diabetologist approach to the eye disease and certain controversies and certain things. You know, I found a quiz question which was, I thought, somewhat probably not correct because, you know, there's no evidence as of now. So let us see what we diabetologists feel about it. So there's a lot of discussion about newer anti-diabetic medications and eye disease. And who else but Shomit Ghoshal, who's a consultant diabetologist at Nightingale Hospital, to tell us about this. Shomit,
You
all yours.
possibly do not know Vinayak. He is one of the best debaters and quizzers in the whole town of Calcutta. We are impressed in every way to see him quizzing and his knowledge of everything. Vinayak, proud of you. And we have Shomit. He is called the, what you call Rahul Gandhi, because he's always on a t-shirt. Whether it's what temperature you have, he's always a t-shirt. And there's another beautiful thing about him. From 2 to 4 p.m. in the afternoon, you will never see him because he's in the gym. So he's very proud of his physique. God bless him.
Thank you, respected chairperson. Thank you, Ophthalmologic Society, for inviting me. I'll be setting the prelude for Kullanda. He has the tough job. I'm lucky Vinagda did not give me the second topic. And the first thing I'll start off is we diagnose our patients with type 2 diabetes based on fasting, postprandial, and HbA1c sugar values. Where did these cutoff values come from? Based on which outcomes? Is it based on heart disease? Is it based on nephropathy? Is it based on neuropathy? This is the seminal document after lots of discussion in Geneva. This is called the Geneva Project by WHO, and this is the most important document I think every diabetic specialist should read in order to understand where the cutoff values have come from. And the cutoff value of 126 came from this document. It's based on retinopathy. There is a continuous relationship between IGT and heart disease. There is no inflection point. So even if you have IGT, you still have high cardiovascular risk. So this cutoff value of 200 postprandial glucose comes from extrapolation from retrofitting the fasting value of 126. How does it match through ROC curve, which is called the receptor operative curve based on sensitivity and specificity. And again, retrofitting the HbA1c of 6.5. So the cutoff entirely for diagnostic diabetes comes from retinopathy. So that is how important retinopathy is, because without it, we wouldn't have a cutoff value to diagnose diabetes in the first place. The prevalence, I saw in the quiz about the prevalence. I'll give you Lancet paper. This is from India, not from a single center, because in the quiz it was from AIMS. AIMS doesn't represent India. So what I need to tell you is this is the global prevalence. 22.7% is a global prevalence for DR, with vision-threatening diabetic retinopathy is around 6.17 and 4% of CSME. India, it is much less as 12.5. One possibility is because it's underreported, is underscreened, and because patients, I presume it will be much larger than or higher values than what we see in the Western population. Because we have a much larger population having nephropathy. So I think our retinopathy also, numbers will be much higher. The most important modifiable risk factor is hyperglycemia. So with this backdrop, what is the role of glucose control? Now, apart from blood glucose, even if you have a fantastic blood glucose control, if the blood pressure, if your lipids are not under control, then you're in a problem. Now, we have gone in a switch mode, completely switch. You see, we diabetic specialists are now switching our modes and becoming obesity specialists, because that's primordial prevention. So we are all going to become obesity specialists from March onwards, because if we can stem obesity, there won't be diabetes, there won't be high blood pressure, there won't be dyslipidemia. That's called primordial prevention. So that is extremely important. Another important area to look out is pregnancy, because of increased angiogenic factors. During pregnancy, an existing background retinopathy can suddenly worsen. So we need to keep an eye out there.
Now, what should be an ideal glucose values to prevent retinopathy, neuropathy, heart disease, stroke, etc., etc.? So this is a meta-analysis we did, and we have been now cited by the German Diabetic Association. They have revised their guideline. It is no longer less than 6.5 and 7. I'll show you the German Diabetic Association guideline. It is 7 to 7.5 is the ideal target for most of the patients. We said 7 and 7.7 is the best target to keep the HbA1c values, because if you go below, then you have certain problems, which was there in the quiz. I saw in the quiz that Accord trial was shown. Now, these are all the trials which has been done. The UK PDS taught us to become diabetologists, 1999 when the paper was published. What was the achieved HbA1c? 7. UK PDS 34 in obese diabetic individuals with metformin, the achieved HbA1c was 7.4. In Steno trial, where one of the seminal papers where there's improvement in all sorts of outcomes, the achieved HbA1c was 7.7. So what we see is that there is practically none of the trials which actually went below 7, except 3 in 2008. Accord Advance and VIDT tried that. It was a disaster. Going below 6.5, there was increase in myocardial infarction, increase in all-cause mortality. So there absolutely no evidence of going below 6.5. There is no evidence of going below 7 also. But the guideline still writes below 7, and that's a big question mark. This is the ACP 2018, created a huge controversy. People were in a shock. They said exactly what we are saying now. There's absolutely no evidence of bringing your HbA1c below 7. 7 to 8 is the target. As a matter of fact, if your HbA1c is below 6.5, cut down your medicines and relax, let the HbA1c go above 6.5. That's a recommendation from the American College of Physicians. This will be shown by Kollanda. I'll not get into it. But rapid glucose control actually in the backdrop of a background retinopathy, if you go for a phaco surgery, it immediately worsens the stage, ETDRS stage. Rather, if you have uncontrolled and go ahead with a surgery, there's no problem. But don't go for rapid correction and then, for example, give an insulin and then go for surgery. It's not recommended. Now, medicine, this was my topic, but there's only one drug to discuss, semaglutide, so actually I was killing time. One conventional drug we have to be cautious about is thiazolidine, pioglitazone, especially when used with insulin. By itself, it's controversial whether it increases maculopathy or not, or induces maculopathy or not. But with insulin, there is an exponential rise of retinopathy. You can have a macular edema when they are used together. Now, newer agents, 2 drugs without which we cannot manage diabetes nowadays from day one are SGLT2 and GLP-1. This is the 2025 American Diabetic Association consensus statement. You can use any drug you want, sulfonylurea, metformin, whatever, but you must have a disease-modifying agent in the form of GLP-1 or SGLT2 inhibitor. Because they protect your kidneys, your heart, your brain, NFLD, now called MSLD. Even now, they have got an approval for osteoarthritis and sleep apnea. We rarely have come across a drug which addresses so many complications by itself. Problem is eye. Now, SUSTAIN 6 suddenly showed that there is a fantastic cardiovascular improvement, but there is a significant increase in retinopathy. And that is a problem which came up. People tried to find out why. Many hypotheses were thrown at us. Some said there was an imbalance between the baseline characteristics. They couldn't find one. The most plausible explanation was rapid reduction in glucose. Now, again, it goes back to the retinopathy slide, right? Rapid correction was worsening your retinopathy. Here, rapid reduction in HbA1c was probably the reason in the semaglutide arm, which is increasing your background retinopathy. We don't know. The answer is going to come from the FOCUS trial. The trial is closed, is ended. No more recruitment is happening. So by next year, we'll know the results. Specifically, retinopathy trial with semaglutide versus placebo, that will answer the question. Till now, I think, except for vigilance, there's nothing else that we can do. And a new entity suddenly sprang last year called NION, non-arteritic anterior ischemic optic neuropathy, again with semaglutide. And these were mainly from observation trial. This is the trial done by the observational data from US. And you can see that semaglutide versus non-GLP-1 therapy, not only in diabetic, but even in obese or the overweight individuals. And this is sight-threatening. This is permanent damage. So we need to be very, very careful about what's happening in this particular spectrum. This is the Danish cohort of more than 4 lakh patients, and it is taking a median duration of 22 months after which the symptoms of NION are manifesting itself. So that's the point. After initiating semaglutide, I think we should be careful about. And you can see in Denmark, as semaglutide was increasing, the prescription was increasing, the prevalence of NION was going up. And then suddenly some of the, the physicians started pulling the plug. So the prescription rates are now dropping down to a certain extent in Denmark, because I think they need answers what exactly is happening. So I think it's the risk-benefit ratio that we need to understand. One hand, we are saving their kidney and the heart, but if the patient cannot see, well, I think that's something that we have to juggle and judge and find out the exact middle space in the near future. Thank you very much.
Thank you. Thank you very much, Omid. I think, shall we take the questions for you right now? That would be nice, I think. Any questions from the audience? Please feel free to put your hands up. I will start off. So, you're saying it's not that important to control blood glucose in a chronic setting, like getting it down to a strict glycemic control.
So all the renal, hepatic, cardiovascular benefit trials, the mean or median HbA1c was 8 to 8.5. So why are the guidelines telling me to go below 7? I don't know. Which one? Obviously, this brother diagnosed with HbA1c was 11 and he said, I will take medicines for 3 days. Because I do not want to be dependent on anyone. You did the surgery, by the way, at 11. Yeah, done.
One question, quite often we see our patients whom we are going for cataract surgery. We have a set limit that, our AIOS guidelines is 200, below 200.
So, Kullan will deal with that. Okay.
All are worried about one thing, Vinay.
This is something related to HbA1c, because many times we see the patients when we ask them to get the blood sugar done, they say, doctor, we have done the HbA1c 2 months back or a month back, and the level is below 7 or something. But sometimes I do insist on getting the fasting and the PP done, and I was astonished to see many times the blood sugar level was 290, 300, and the fasting was somewhere around 130, 140. So in these situations, we can't do the surgery. So whether to depend on...
We will come to that.
That is Kullanda's topic.
We will come to that.
But from our perspective, if fasting and PP is normal and HbA1c is high, we normally go for a continuous glucose monitoring to find out other part of the day when the sugars are actually going high. Because fasting and PP is normal, so what do we do? So we have to...
One thing we often come across is that, patient having around 300 plus blood sugar level and also advanced cataract. So we recommend the patient to get admitted, to get insulin and control the sugar level. But you're saying that we shouldn't go for rapid
I will not comment because this is his topic.
So we will come to that.
Okay, I've got a question for Shomit.
But let me ask you, obviously you are looking at retinas all the time. How frequently are you seeing NION?
Nowadays we are getting it more frequently.
More frequently?
Yeah.
In diabetes?
Yeah. And my question to Dr. Samit, excellent talk. How often do you see NAI when you started semaglutide?
I have never seen one, so I cannot...
I have also not seen one. Kullan? No, none of us have seen one.
So can we, look at those data and look at what drugs they are on?
Can we please
we should have a
find
study, our own study here, whether they are on semaglutide or not.
Yeah, but I think the first thing is that we need to get a heads up from you, telling us that, that we are starting to see, all of us know each other some way or the other. So, simple phone call that, Vinayak, your patient on semaglutide has NION.
I think we should have a registry sort of thing.
No, but I think more important, Binagda, is if we say that this is a diabetic patient not on semaglutide has NION, this patient on diabetic on semaglutide has NION, then see, cause and effect relationship will never come. You will never be able to prove semaglutide causes it. But you can find some associative factors.
Actually, diabetes itself is an independent risk factor for...
Numbers are in thousands and millions. Yes. But NION is a rare disease, isn't it?
No, it's quite common, and particularly with actually diabetes, hypertension, they are independent risk factors for NION also.
Right.
So it's very difficult to differentiate between whether it is due to semaglutide
or whether the disease.
The disease itself.
But the interesting data is, from the prescription pattern in Denmark changing, going up tremendously and then coming down. I think an area to watch will be whether the prevalence of NION came down after the prescription of semaglutide came down. That is something we need to look at.
And whether parallelly tirzepatide prescription went up.
So there is of course a... Yes. And there's also this market forces at play, and so, it's difficult to actually tease out what exactly is going on. Shomit, thank you very much for this lovely presentation. Let me welcome on stage Dr. Kullan Gangopadhyay, a good friend, a colleague, and a wonderful orator. And I don't think I could have found anybody else to do this presentation other than Kullan, because he's going to be talking to you about all your burning questions. All the questions that we've had is related to his topic. So it's all yours, Kullan. You will tell us about pre-cataract glycemic control. How good is good? Thank you.
Thank you, Vinayak. I thought it was 15 minutes, but it's 12 minutes. So I'll try and be quick.
We'll give you 3 extra
okay.
minutes.
I thought I will ask Vinayak, the dhal torwal ache kina, because I think I'm going to be showered with stones after I finish. It will be a bit controversial. So that is what I want. Well, amar to chok chhana bada hoye gelo, pun intended, after reading all this and going through in detail. So I will show you, these are hypothetical cases, but that mirrors the experience that I've had with patients. So here is 85-year-old male, diabetes for 25 years. This is fasting, this is PP, this is HbA1c. Surgery holo na, better control. পেশেন্টের মেয়ে এসে বললেন যে আমি ছুটি নিয়ে এসেছি স্পেশালি এটার জন্যে এক সপ্তাহ, আমি কখন ছুটি পাবো জানি না, বাবা হলো দেখতে পাচ্ছে না, না দেখার জন্য পড়ে গেছে গুঁতো খেয়ে, কিন্তু হবে না অপারেশন। আপনি লিখে দিন, আমি লিখে দিলাম, প্লিজ মে প্রসিড ফর সার্জারি, হলো না। Second, newly diagnosed type 2 diabetes, fasting 280, PP 495, HbA1c 13.8, surgery cancelled. Okay. Third, this is what the gentleman was alluding to, fasting 110, PP 156, HbA1c 6.8, picture perfect, খুব ভালো। ওটি টেবিলে যেদিনকে এলো, ব্লাড সুগার ওয়াজ 230, নেমে পড়ুন, হবে না। Then last, 62-year-old male, fasting 160, PP 248, look at the duration of diabetes, 18 years. HbA1c was 8.8. 1 month ago, HbA1c was 9.4. Some medications were adjusted. His blood sugars were beginning to come down now. It was now 8.8. Surgery cancelled. And this hurt me. একবারে ভেতরে লেগেছে। বলে একদম ভালো ডায়াবেটিস কাকে দেখাচ্ছেন? ও একদম ভালো ডায়াবেটিস ডাক্তারকে দেখান। হ্যাঁ, বলে নট অনলি দেখান, চটপট এক সপ্তাহের মধ্যে তাড়াতাড়ি গুড গ্লাইসেমিক কন্ট্রোল করতে হবে। দিস রিয়েলি অ্যাঙ্গার্ড মি। আমরা কেন আমাদের এগেনস্টই কথা বলি? এনিওয়ে, সো ফর জাস্ট সিম্পলিসিটির সেক, দিস ইজ দি HbA1c। যদি 9 হয় তো ব্লাড সুগারটা এই 170 থেকে 250। তো আমি এই ফিগারটা একটা রাফ আইডিয়া দিয়ে রাখলাম, 9 মানে ওই 170 থেকে 250 অ্যাভারেজ এটা হবে। বেশ, তাহলে আইডিয়াল HbA1c কত হওয়া উচিত? Shomik had just told you about it. 7-এর নিচে না হলে অপারেশন হবে না, গাইডলাইনে লেখা আছে। কে বলেছে 7 হতে হবে? See, if there is a 40-year-old chap, fit and well, ওর আরও 50 বছর বাঁচবে, নিউলি ডায়াগনোজ ডায়াবেটিস, ওকে 6.5 টার্গেট। কিন্তু একটা 80-year-old নিউলি ডায়াগনোজ ডায়াবেটিস, for him it should be 8 or even 8.5. মাঝখানে এখানে এলো, this will be 7.5. প্রত্যেকটা মানুষের আলাদা আলাদা HbA1c টার্গেট থাকবে। ইট উইল নট বি দ্য সেম। ডোন্ট সে 7% হতে হবে। ইউ ক্যানট বি ডগম্যাটিক, অ্যান্ড দ্যাট ইজ রং। ইউ উইল বি হার্মিং দ্য পেশেন্ট ইফ ইউ পুট আ ফিগার অফ 7% ফর এভরিবডি। অফকোর্স শুনবে। কনজিউমার স্কোর যদি আপনি হাইপোগ্লাইসিমিয়া হয়ে পড়ে যায়, কনজিউমার স্কোর আপনাকে টানবে, কেন আপনি ওষুধ কমাননি। This is standard. This is, I have written at the bottom, American Diabetes Association 2025. This is world recommendation, not only ADA, AACE, European Association for Study for Diabetes. I can give you anything you want. Okay. Not only that, this is the time in range, and if you look, 70 to 180 এর মধ্যে 70% উপরে থাকলেই হবে। তার মানে 30% কেসে sugar can be more than 180. Okay, that is the time in range. So now, what do the diabetes guidelines say about what should be the sugar levels for surgery? Now, I will tell you first for surgery in general, not cataract, in general. So this is the ADA 2025. তারা বলেছে 8% HbA1c নিচে। এই সার্জারি ক্যাটারাক্ট স্পেসিফাই করা হয়নি। This is for, so I will say bypass surgery. সিভিয়ার অ্যাবডোমিনাল খারাপ অবস্থা, তার জন্য এটাই 8%। নাও নেক্সট, জয়েন্ট ব্রিটিশ ডায়াবেটিস সোসাইটি ফর ইনপেশেন্ট কেয়ার for general, not for cataract. 8.5%. So a patient who wants to undergo a CABG comes with an HbA1c of 8.5% will not be refused surgery. With severe sepsis, needing surgery, 8.5 will not be refused surgery. If you refuse, then you have to answer in consumer court why you have refused. So now I looked at ophthalmological guidelines. I could not get the guideline which you were discussing, my fault. I thought you will all be here, so you will help me out. This is the one which I could dig out. Here it says, random blood sugar less than 200, urine sugar, if positive, surgery should be done later. Now let me point out, we do not look for urine sugar anymore, because there are drugs which push out the sugar from the blood into the urine. So if blood sugar is excellent, but urine sugar is 3+, it means the drug is working. So we don't look at urine sugar at all. And this random sugar of 200, so I just showed you the patient, HbA1c is excellent, well controlled. So khali shedinke sokhale bodhe oshudha khete bhule geche, stress hoye geche, sugar ta 220, you're refusing it because the guideline says less than 200. Next, European Society of Cataract. This is the draft statement that has not been published yet. ওখানে বলেছে, patients undergoing cataract surgery, history and physical examination, 3 randomized clinical trials have failed to show that it reduces complication. And routine pre-op laboratory testing, of course that includes sugar, routine pre-op laboratory testing in a large study did not reduce perioperative mortality or morbidity. আমি কিন্তু বলছি না, এগুলো ইউরোপিয়ান সোসাইটি, আমেরিকান একাডেমি অফ অপথলমোলজি, প্রি-অপ ইভালুয়েশনে 5 বার পড়েছি, কোথায় HbA1c আছে, কোথায় সুগার আছে, কোথাও পাইনি খুঁজে। Nowhere. It's not written. Routine pre-op laboratory testing in association with the history is not indicated. টেস্টই করতে বলছে না, তো লেভেল কোত্থেকে আসবে? Next, and then this is Retina Today one magazine, retinal magazine, where they mention in Japan, they look at HbA1c of 10% for cataract. 10%. I was very, very disturbed at this stage. আর আমি যে হয় আমার বিমূর্তি হয়েছে, নাহলে কিছু একটা গন্ডগোল হচ্ছে, আই এম মিসিং সামথিং। এ কি পেশেন্টদের আমরা 120-50-এ রিফিউজ করে দিচ্ছি, 7 পয়েন্টে রিফিউজ করে দিচ্ছি, এরা বলছে মাপবেনই না, আর 10%। So I contacted my friend in UK, he'ও রিটায়ারমেন্টের স্টেজে চলে এসছে, more than 30-35 years experience. So this is my WhatsApp conversation, okay? This is me writing, do you routinely check blood sugar of diabetes patients before cataract surgery? If so, at what level of sugar? Fasting, PP, HbA1c, do you cancel or defer surgery? Is there any trust policy? Trust মানে 2-3টা হাসপাতাল মিলে একটা ট্রাস্ট ওখানে ইউকেতে। So ফেরত পাঠিয়েছে, we do not check blood sugar routinely on the day of cataract surgery. বলো এই হলো গিয়ে ট্রাস্টের একটা পার্ট পাঠিয়েছে, সেখানে ডায়াবেটিসের ইজ রিটেন হিয়ার, ব্লাড সুগার মেজারমেন্টস আরন্ট রিকোয়ার্ড অন দ্য ডে অফ সার্জারি আনলেস দ্য পেশেন্ট ইজ আনওয়েল। ইট ইউজ টু বি ক্যান্সেলড বিএম, ওরা সিবিএসকে বিএম বলে, মোর দ্যান 20 মানে 360। In the past it used to be cancelled if it is more than 360, not anymore. আমি আবার বললাম, just to clarify, for your trust, there is no cutoff for HbA1c or sugar levels. Am I right? You are correct. Previously, we used to have 360. That has been taken off now. We do not check blood sugar levels for surgery. Of course, diabetes patients pre-assessment clinic, কবে হয়? Anywhere between 1 week to 6 months before surgery. তখন যদি সুগার 360-র বেশি থাকে, জিপিকে ফোনে জানিয়ে দেওয়া হয়, ভাই আপনার পেশেন্টটি ভালো নেই, সুগারটা, অপারেশন আমরা করে দিচ্ছি। We do not cancel the surgery. We do the operation. So it's something very grossly wrong here. What is happening? Okay. So another point is, to bolo jare ei patienter বহুদিন ধরে sugar is staying sky high. So I am doing a favor asking to rapidly bring down the blood sugar. What is wrong? I am trying to normalize a person. So if you look at the evidence, so this is one trial we think Shomit was alluding to. Post-op progression of diabetic retinopathy and maculopathy in patients who underwent cataract surgery, type 2 diabetes patients. They divided into 3 groups. One group who had very poor glycemic control before surgery, Kintu were aggressively managed and got the blood sugar down, one group. Second group, poor before surgery, poor during surgery, poor after surgery. Nothing was done. And the third group, good to begin with. So clear, 3 group. Their outcome, okay? So what they found was this, you see, rapid correction group, their HbA1c was 10.5, 3 months before surgery was 10.3, so within 3 months they got it down by about 3, got it down to 7.4. And it remained 7.4 up to 1 year after surgery. Poor control remained poor. And good control remained reasonable, 7.5. Eighth intake group outcome key. So at the bottom you see, no diabetic retinopathy, mild and moderate to severe. So those group who had a rapid correction, 70% of them who had moderate to severe retinopathy worsened. And যেখানে poor control, তার only 30% worsened. Maculopathy, again 70% worsened, আর যাদের poor control রয়ে গেল 30% worsened. So what they concluded was rapid pre-op glycemic control should be avoided in patients with moderate to severe non-proliferative retinopathy because it may increase the risk of post-op progression of retinopathy and maculopathy. এই যে এতদিন ধরে বেড়ে আছে এক সপ্তাহের মধ্যে ফাট করে নামিয়ে দাও, that is bad, that can hurt your eyes and let alone the rest of the body, which I'm not going into. Okay, so problems with rapid correction, I don't think I have got time. So shorte bole di keno eta hocche, we don't know. But probably rapid correction of blood sugar increases the blood flow suddenly, arteries are damaged, increasing blood flow করলে reperfusion problems আরম্ভ হয়, leakage আরম্ভ হয়, inflammation আরম্ভ হয়. That is probably the mechanism. We don't know for sure. So rapid মানের কত rapid করলে we can damage the eyes. So this is one trial, Kumamoto, which suggested that a decrease of HbA1c by more than 3% এখানে within 3 months. 3 মাসের মধ্যে 3% নামিয়ে দিলেই we begin to develop retinal edema, retinal hemorrhage, soft exudates. So that's what happens. I'll just take 2 minutes more. So advice for physicians therefore was that if diabetes is more than 10 years duration, HbA1c of more than 9% for at least 3 years, particularly patients with moderate or severe retinopathy should not receive rapid correction. When an experienced surgeon performs small incision cataract surgery, the influence of pre-op blood glucose control seems to be small. So ADA, যেটা আপনি বলছিলেন কনজিউমার কোর্টের ব্যাপারে, তাহলে HbA1c যদি কম থাকে তার আপনি সেট করে দিয়েছেন 80-year-old, for that person HbA1c target is 8.5. So if you say 7.5, কেন করলেন 7.5? You now cut down on the drugs, get it up. So what is the evidence, what I have said so far, যে কন্ট্রোল করে লাভ নেই, এটার কোনো এভিডেন্স আছে? So evidence dates back to 40 years ago, 1985, যেখানে retrospective study of post-operative morbidity in patients with type 2 diabetes. ওখানে দেখা গেল diabetes patientsদের lower blood glucose যাদের ছিল তাদের বেশি complication. Second, visual outcomes after cataract surgery in patients with type 2. This is more recent. This is retrospective data of about 65,000 patients. There, they found this, that worse post-operative vision increased with severity of retinopathy, duration of diabetes, but not pre-operative blood sugar. Pre-operative blood sugar vision losses সাথে associated ছিল না. Again, acuity, best, what is that? I forgot the full name, visual, best corrected visual acuity was not associated with elevated HbA1c. So patients, we see no evidence that cataract surgery should be delayed among diabetic patients with elevated HbA1c. নো, সেটাই এতক্ষণ তারা তো গাইডলাইনে থাকতো বড় বড় করে যে দেবেন না, অপারেট করতে দেবেন না কিছুতে, এতক্ষণ না ইট ইজ অ্যাচিভ। টার্গেটই নেই, চেকই করতে বলছে না, দেন ওয়্যার ইজ দ্য ইনফেকশন কাম? আই এম সারপ্রাইজড মাইসেলফ রিয়েলি। Cochrane, 2019, this is the last 2 or 3 slides. Again, intraoperative ocular events, pre-op testing versus no pre-op testing. Pre-op versus no pre-op testing. There is no difference in intraoperative ocular adverse events. You can see here both medical adverse events, ocular adverse events, kintu cost 3 gun beshi if you do pre-op testing. This review has shown that routine pre-op testing does not increase the safety of cataract surgery. So, to summarize this, there is absolutely no reason why this gentleman should not have his cataract done, why this not been done, and why this person should not have it done. এখানে I can understand কেন, কারণ এটা টাইপ 1 ডায়াবেটিস কিনা আমি জানি না, very high blood sugar levels, the stress might tip her into decay, I don't know that. So, therefore it needs correction. But these three, there is absolutely no reason why it should not get it done. Because you understand, if you're not doing it, you think you are doing a favor, but the infection টা দেখলে চোখটাতে আপনার কে দেখবে ইনফেকশন যদি হয়ে যায়? But this person might fall down the next day and break his hip, as has happened many times. যেটা দেখতে পারেনি, অপারেশন হয়নি, পড়ে গেল, মেয়ে আসবে 2 মাস পরে ছুটি পাবে। So that's my last slide. So glycemic control does not seem to be as important in cataract surgery versus non-ophthalmological surgery. Bypass surgery te maybe it has good role, clear evidence royeche. Cataract ami to khuje paini. Too quick glycemic control can be detrimental for both the eyes and the rest of the body. The cutoff for HbA1c in the international guidelines start from 8.5 to no cutoff. Arbitrarily cancelling surgery has physical and financial implications. We urgently, this is the most important line, we need an Indian guideline jointly with the ophthalmologists, diabetologists, endocrinologists together with evidence. The guideline which is there, which you have shared, fasting is less than 128 and PP 140. Where is the reference? Where have you based it from? You have based it from extrapolating it from the guideline for the non-ophthalmological surgery. So this is what we need. Thank you very much.
Thank you. So I'm glad you're clapping and not throwing brickbats. Oyon.
Last but one slide. I mean,
Excuse me.
Yeah.
Excuse me, can I say something? I need to be heard.
Yes,
I
of
have
course.
never heard such an excellent lecture.
Okay, thank
you know, I mean, at least somebody has supported me, because all along, to my friends, I've been saying anybody in their 70s with a history of diabetes for 12, 14 years without any retinopathy, with arteriosclerotic changes in the vessels, needs their blood sugar, HbA1c, to be less than 8 or between 7 to 8. And none of them would hear that, you know. Thank you so much.
Thank you.
The previous slide.
Previous.
এইখানে এই 45 ইয়ার্স ফিমেল যেটা আছে আর কি, এর সুগারটা যদি 85 ইয়ার্স মেলের মতো হতো, নিউলি ডায়াগনোজ, তাহলে আমরা করবো কি করবো না?
অবশ্যই করবেন। আরে what I am saying is জয়েন্ট ব্রিটিশ সোসাইটি 8.5 নন ক্যাটারাক্ট সার্জারির জন্য ওকে করে দিয়েছে। তো যদি বাইপাস করতে পারে তো ক্যাটারাক্টটা কেন করতে পারবো না? আমার সেটাই বক্তব্য, যেখানে বাইপাস একটা ভ্যাসকুলার একটা সার্জারি। সো 8.5 you can easily choose as the cutoff.
So I'll tell you, I'll stop you there for a second. There is no evidence that high blood glucose causes increased infection in any surgery except for cardiac surgery.
We are not actually talking about infection, but what we have seen with uncontrolled diabetes, there is progression of retinopathy even without pre-operative retinopathy, and again those who had retinopathy, there was severe progression of maculopathy in uncontrolled diabetic patients, even in uneven full cataract surgery.
So I'll tell you that. So there is some, what you have said is right, there is some data to suggest it. But the point is, in those patients, we should not attempt to get that blood sugar control quickly.
No, never.
We would
Quickly,
take a lot of time.
That it will worsen retinopathy.
It will take a lot of time.
Yeah.
Then you have to wait for maybe 6 months to a
Since
year.
cataract surgery is an elective surgery, and if it is not that significant, so better to get the blood sugar.
Yeah.
Yes.
But again, I would again ask this question: why worldwide the guidelines have not asked for an HbA1c or blood sugar then for before cataract?
That is
And this answer,
ridiculous.
this question, I need an answer from you. Why? If
And-
this
and-
is so important, why have they not?
Actually, we should have our Indian evidence-based criteria because we should not compare with the Western countries.
No, but
because
you
the
know,
profile-
We take everything Western data, we read Western books, but for this, why we will be not? We have to satisfy that there is no data to suggest that good glycemic control doesn't have an impact on cataract surgery. It will not change whether you are Indian or not.
No, we are concerned about the retinopathy.
Those patients there, significant proportion were blacks, Hispanics and Asians, not just white patients.
No. Actually,
No. What
that
he's
is
saying,
important.
what you're saying is very correct. You know, progression of retinopathy. Kollan's counter question to you is why is it not mentioned in any guideline across the world? And I'll tell you something. What is interesting to note that he showed you ADA data. He also showed you most of the papers that he was quoting were ophthalmology papers. He wasn't quoting you diabetes papers. He was quoting you ophthalmology papers. And worldwide, ophthalmologists are not saying that this is a necessity. Okay.
What else? We are just extrapolating. যে bypassed বলেছে অত left figure আমরা ওটাতে করে দিই. This is my objection.
Kalyan, I'm very thankful for you
I
for bringing
think
this
because
up.
cataract surgery
At,
has
one second.
At All India Ophthalmic Society meeting some years ago, I had stood up and very bravely said that the only investigation you need before cataract surgery is a biometry. Now, agree with Debashish, if you're operating on a 6669 cataract, a patient who's not visually really disabled, has slight problems driving at night, get him to control his diabetes 6-8 years, over 6-8-10 months, 12 months, because that patient is not really suffering from his cataract. Fair point, taken. But if a patient is suffering with cataract, blood sugar is 350, so what? It's been like that for 10 years.
Absolutely.
And we used to do this routinely, your friend is right, we used to do this routinely in the UK. We never tested for blood sugar before. Before that is a diabetologist's job, they are doing it. I trust my friend. If he says it's all right, it's all right. And I don't even ask, I presume it's all right.
I mean, thinking back, Vinayak, I don't know, you must have done the same. I have never received any referral from ophthalmologists in UK.
No, I never did.
Correct.
Is the guideline same for all types of eye surgeries? Like say refractive surgeries and what do you suggest? Say a young diabetic who's coming up for a refractive surgery. So is it the same?
So because cataract is the more commonest surgery.
Yes, that is the
So
commonest.
the other diabetes bodies, they have not segregated the cataract from non-cataract and
Correct.
ophthalmology, non-ophthalmology. They just put everything together. That is what the
For all
confusion arises
surgeries.
from. What we say is, oh look, they have said this, so for cataract also we should say this. They have not segregated it. But even for the general surgery, they have put it 8.5%, which wasn't there before.
For
They
a
8.5%.
juvenile diabetic
For a type
person,
1 diabetes, I can understand, because, a stress can precipitate, diabetic ketoacidosis. Therein, I think there's a reason to, there's this thing, 20 millimoles, so it's around 350, 400 if the sugar is there. Okay, if you want to postpone it, I can understand. But recently, I had this experience with a very...
instead of postponing, maybe we can delay it.
Delay it or
Ask for a
something.
better control over
Recently,
time.
about 6 months back, a very senior ophthalmologist called me up and told me that this patient, you have certified that he can go ahead for surgery. I will not touch him if his blood glucose is not less than 160.
This is wrong.
This is wrong.
This is my objection.
Shugoto did the surgery the next day. The very next day, Shugoto did the surgery. And, this lady is just fine. There's no problem at all 6 months down the line. And she's ever grateful to Shugoto for doing it because she was really not being able to see it at that point of time.
No, but counterpoint is that Binayak, infection hole ki ami dekhbo na uni dekhben.
No, no, true, but you know, পড়ে গেলে কি আমি দেখব না?
that is the counterpoint which happens. But the point is যে আমাদের নন ডায়াবেটিক পেশেন্টদের কোনোদিন ইনফেকশন হয়নি।
হ্যাঁ, true, true.
There is world data which suggests there is no increase. Just one patient of year, if he has infection, it is due to this.
Sir, we do face questions from the...
Paragda, you want to say something?
Yes. Apart from
Correct.
Exactly. Exactly.
Ek minute, Vinayak, Dr. Parag Mukherjee senior.
Yes,
He
please.
wants to talk.
apart from the retinopathy part, we are more apprehensive on the healing part and the infection part. We have forgotten that our incision has been reduced from 180 degree of cornea to only 2.8 or 2.2 even through an avascular part. And we are targeting also one avascular object. Lens is avascular, cornea is avascular, which heals on the next day spontaneously. No question with blood sugar because it is not related to blood or blood anyway, this surgery. So it is not that big incision which will heal after 7 days or a scleral incision or a vascular cut. It is only a 2.8 cut and targeting one avascular structure.
Thank you, Paragda, but one thing I'll tell you to Paragda.
Why so much
Okay,
apprehension
okay.
with blood
One-
sugar? Not related to
Okay,
blood
okay,
sugar.
Paragda.
Blood
I will tell you one thing. Diabetes is our mental block.
True.
The truth is, it is our mental block. They have cleared. But I will ask the house, how many of you are convinced from today, tomorrow you are not going to do blood glucose? Please raise up your hands.
We will do, but we will not
Did
be
it-
so
how many of you are really convinced by his speech?
Yes, of
Be
course.
true to yourself.
Sir, but one thing...
I need him to write it, fit for surgery. Fit for surgery.
Fit for surgery,
If
sir.
I'll tell you something. You doctors can write it, we doctors can operate.
do
Yeah,
it.
yeah, you know.
No, no, no.
No, so the point is you are not
afraid
convinced.
about one
No,
thing,
no, no,
only
sir,
the
it's not
Consumer
that. I'll
Act,
just tell you
Consumer
one
Act,
thing.
nothing else.
One
The
thing,
only
one
thing
thing.
we are afraid is about litigation.
No, that is why the last point is very important. We need to come out with these guidelines
correct.
jointly.
Sure.
I think this is
Shomit,
most
you
That's
wanted
that's the point. That's the point.
last word. I'll let Shomit have the last word.
I've got one question, sir, if you allow. Before Shamit, maybe. He will have the last word. I just have a query about the blood retinal barrier. How is it affected by the level of glucose? Can anyone, maybe you or maybe you, because we are also, we need to address that. The blood retinal barrier maybe has an importance in our inflammation that comes. Fundamental question, whether that is affected. Yes.
I do not have the answer exactly, but one thing can I see, hyperglycemia, chronic hyperglycemia, that triggers inflammation, and those cytokines and chemokines, they are responsible for breakdown of the blood retinal barrier. So there must be a correlation between the hyperglycemia and the breakdown of blood retinal barrier.
What they've said is that so there is a bit of narrowing of the blood vessels to begin with, hyperglycemia, and then you suddenly reduce the blood sugar, then there is a sudden dilatation. So there is a diseased artery, pipe ta puro ebro khebro hoye ache, and suddenly you increase the force. So that causes rupture of these, inflammation, leakage, permeation of proteins and stuff.
Yes,
So that's what the
that is for rapid,
Correct, rapid,
correction. I am talking about the chronic.
Chronic
hyperglycemia.
is the endothelial lining, the attachment of the extra sugar with the proteins.
Yes.
And then once it exceeds, then the inflammation starts in,
Right.
the inflammation spreads.
Right.
Yes.
One question for setting up a guideline like OSWB guideline or a general consensus that henceforth we are going to check only HbA1c, nothing else?
So
No, just
the
for general
worldwide, the
consensus.
guidelines is no check.
let me.
It's not that we can't do anything. Without doing, we can't do.
Yeah, I understand. So I think even I'm uncomfortable with not doing anything. I'll follow a middle path now. So if we don't do anything, then we are a bit uncomfortable that patients might come and accuse us, why have you not checked its sugar level, because Dr. B does it and you have not done it. So I think in our guideline we will end up checking the blood sugars, which should be, I think, both fasting PP and HbA1c, but our target should be much less relaxed much more relaxed than what we are currently following. It should be at least HbA1c of 8.5 upwards. Fasting should be excess of 160, and PP should be less than 250.
So your recommendation that we check all the three.
If you check, you should check all the three, because the confusion will start. HbA1c bhalo ache, very fasting PP bere geche. Just like I showed you the patient, her HbA1c is very good, meaning that her glycemic control is very good. On the day of the surgery, she forgot to take her medicine, stressed, blood sugar up, eitto hobe na.
It's not only for diabetes. If you check a patient before surgery for hypertension, how does it go in? Out.
Okay, show me.
Let's go on. Okay, thank you so much. Okay.
Any recommendations for VR surgeries, retina surgeries,
Okay, the
patient
chair-
undergoing diabetic retinopathy, vitrectomy?
We'll have the guidelines are the same. Guidelines are the same. Okay, let me introduce a young dynamic diabetologist, Dr. Amit Kumar De, who's going to enlighten us with diabetes and AI. So we are taking this to another level, all about artificial intelligence.
Okay, so good afternoon, everyone. And after Kollanda and Binoyakda has broken the jinx, please don't start the timer. Just allow me 30 seconds to ask a few questions to this audience to understand how much AI literate and tech literate we are. So first question to the audience, a quick raise of hands. How many of us sitting here really fear that this artificial intelligence one day is going to replace us and take my job away? Hat tule din. I'll become jobless. Right? Okay. How many of us, not the majority, okay. So how many of us have explored any AI tool, say for example, ChatGPT, for asking a clinical question or a query? Most of us. So we had sir asking this question right now. How does the blood-retinal barrier get affected by the level of glucose? I typed this in GPT. Okay, I will give you just the top layer of answers. It says, number one, increased vascular permeability, pericyte loss and capillary dysfunction, polyol pathway activation, advanced glycation in products, loss of retinal pigment epithelial integrity. Clinical implications, non-proliferative diabetic retinopathy, PDR gets increased, chronic hypoxia-induced VGF upregulation, and diabetic macular edema. Happy with this answer? So you find it useful? Okay, now you can get with the timer. Now you can start the timer. All right. So my task is to introduce to all of you about the whole domain of artificial intelligence that's not just going to improve diabetes management, but revolutionize medicine as a whole. The discussion that we just had at the moment is a clear understanding that we are at one end of the spectrum, the evidence is one level, and somewhere we are floating in between with our confusion. And why is this? Especially in diabetes management, because one size does not fit all. You have to weigh the risk-benefit ratio at even given point of time. So like, there's no clear-cut answer. HbA1c, eta holei korbo ki korbo na. Every patient is individual. Every patient will have its priority. At the end of the day, dekhte hobe koto grade of, what is the extent of the cataract? Is it going to cause blindness? Could that lead to the patients falling down? If yes, then I will operate. Or is it that the blood sugar control is more? So, I'm trying to say is that we cannot generalize everybody. We are in the era of personalized medicine, or as we call it, a most hyped term, precision medicine. So, artificial intelligence is going to help us get that. So now, how do you get the whole spectrum of AI revolved? You will have personalized treatment with virtual health assistant, predictive analytics, drug discovery will get escalated, treatments will get optimized. Treatment like this, which is controversial, cataract surgery, korbo ki korbo na HbA1c yato, optimizing surgeries and remote AI monitoring. In diabetes care, I think we are 3-4 diabetologists in the house, and all of us will agree that these are the challenges that we face. Early disease detection, early complication detection, lifestyle changes, cost of care, adherence to the care, education gap, bolchiak korchiarak, psychological impact, complex treatment plans, communication barrier. Can AI solve this problem? Let's explore this in the next 12 minutes. But the first question we'll ask is, why artificial intelligence? All this time, what Shomita and Kollanda said is just the tip of the iceberg. we were talking about evidence-based diabetology, evidence-based medicine. For the first time, we will have access to data if we use AI in the right way to give us more insight and get into data-driven intelligence, precision medicine or precision diabetology. This is the power that artificial intelligence holds, not just to revolutionize diabetes management, but to revolutionize healthcare, even ophthalmology for that matter. So now, what are the areas where we find AI can help in diabetes management? Diabetes risks prediction, self-management education. Chokher kibhabe, what are the complications that can happen in my eye and how frequently I should get myself tested? In insulin pumps, in diabetic retinopathy screening, in foot complication screening, and in something called clinical decision support system. We have got predictive machine learning algorithms which are being developed and which will keep on evolving, which can give up risk stratification and prediction of diabetes in a more geographical area, in an ethnic strata point of view, or in a demographic area. Now, we all believe that there is a role of diabetes self-management education, and that education is the key. It has to continue beyond the clinic hours of the doctor. So we can use virtual AI chatbots to enhance that. And why is that important? Because there is this concept of just-in-time adaptive intervention. It means if you hit the patient, not hit as in hit, if you impact the patient with the right information at the right point of time, you're able to bring a behavioral modification in that patient's cognition. And that is going to impact in the long-term clinical outcome of the patient, especially in a chronic disease like diabetes. Let's look at diabetic retinopathy now. Now, there is a segment of AI called deep learning which has been explored to screen for retinopathy. So one of my friends called me up 5 years back, ophthalmologist I said, why do you say that? Because retina screening is their job. How can diabetologists screen for retinopathy? In fact, what has happened is I've been using fundus cameras in my clinic for the last 7 years, and I think my referrals to Aniruddha has increased over the years because now I can screen out those non-proliferative and proliferative diabetic retinopathy earlier than they used to get detected and refer to him for intervention at the right point of time. So in 2018, US FDA approved the first AI algorithm developed by IDX, Topcon fundus camera, as a standard way for diabetic retinopathy identification. So exactly Hoitaki is a 5 minutes test, capture, analyze, and fatak se report aa jata hai. How is that happening? It works through the principle of deep learning, which means it has been trained with an image of a dog, that this is a dog, with an image of a cat, this is a cat. First step, data gathering. So one-to-one labeling, annotation, this is hard exudate, this is cotton wool spot, this is a microaneurysm, etc., etc. Labeling, so that there is explainability. After the stage of data gathering, there is a stage of labeling or pre-processing or feature extraction, as they call it in the, in the world of machine learning. And after that, it is run through multiple layers of iteration. More the number of layers, better is the sensitivity and the specificity of the output. And then you finally get a report. And this is the one which I'm talking about. I've been using Artelis cameras in my clinic, and we have worked on the AI algorithm on it. It even classifies and gives a prediction of diabetic retinopathy in the ICDR scale. You can see there in the below. It's not very visible, but in the ICDR scale-wise, it classifies as no diabetic retinopathy, mild, moderate, severe, non-proliferative or proliferative diabetic retinopathy. But the good thing is, it is able to detect 100% sight-threatening retinopathy. That is the most important advantage. Do we have evidence again, the tip of the iceberg? Yes, this was one paper we published 2-3 years back in ATTD, and where we looked at the sensitivity and the specificity of this, and we had compared that with the findings of an ophthalmologist, and we found almost 97% sensitivity and specificity in an AI algorithm versus an ophthalmologist. We also conducted a community screening in Chandni Chowk in Kolkata, and this was a community screening, not a diabetic patient screening. We did this with a sample size of 5,000 patients, and where we found that in the community there was a prevalence of diabetic retinopathy detected by AI algorithm of 13.7%, which kind of matched the general prevalence of diabetic retinopathy in India. And the prevalence of diabetic retinopathy in patients with hyperglycemia in that subpopulation was 38.2%. This was a random community screening. Now you have similar methodology of imaging and taking a pattern out of that image and giving you a prediction. How is it giving you a prediction? It is based on that algorithm. It is exactly what we do. How we have been taught, our minds have been taught, right? When your patient walks into your clinic, you start diagnosing, you create a pattern of the patient in your mind, and then you reach your provisional diagnosis and differential diagnosis. This is exactly how the algorithms have been trained. So in a way, these algorithms are actually augmenting our intelligence. So we don't call it artificial intelligence. We call it artificial plus human intelligence, augmented intelligence. So just like retinopathy, just to give you a broader spectrum of application, there is thermal imaging of the foot, which can help us in primordial prevention and picking up of heat spots or hot spots, which can predict that individual will have a increased risk of neuroischemic foot ulcer based on his gait pattern or the pressure points in the feet. As we go along this era, in 2025 and 6, we will be finding developments of agents, AI agents, which is called agentic AI. And these agents are going to be integrated to function along with the clinician, with making this loop of a clinical decision support system. It means if I have a controversial question like this, my patient has got, let's say, a grade 3 mature cataract and HB1C is this, what is the recommendation that should I go for surgery or not? So you can ask this to a CDSS and then take the decision with the help of augmented intelligence. And what will the CDSS be based on? The relevant guidelines and the data from where it is going to learn. Of course, for that we need data, and that data needs to come from the electronic health record corpora. Okay, so we also find that what I just did is we asked ChatGPT to generate an answer. So we believe that this conversational generative AI can actually help us improve communication and education to the patient. Does all of us in this room have a phone, Android phone? Can you show it to me? All of us? Can you take out the QR scanner? Now this will tell you how much tech savvy you are. Khuje ber korun, kothay QR scanner ache. All right, take out the QR scanner, because now I will be giving you some QR codes and you need to quickly scan and start exploring it. So what we are trying to say is that with generative AI, a tool similar to ChatGPT, we can have diabetes self-management education that can give the patient instant response, medication clarification, bring in that just-in-time behavioral modification, give access to health information and personalized answers. So that is the powerful methodology of this tool if used in the right way. Besides that, what about diabetes distress? So the mental health support can be provided through these chatbots. This is a paper where see, this is the, how I never even told you, but you started scanning because you saw a QR code coming up right on the screen. So this was a paper that we published about the whole spectrum of AI in healthcare. But what I'm going to show you now is what I want each one of you to try. So we believe that there's going to be agents called agentic AI that will act in parallel to the clinician, whether I'm a diabetologist or an ophthalmologist or a surgeon, blah, blah, to enhance my clinical decision making with autonomous monitoring and personalized patient support and engagement, thereby reducing the administrative task and helping the clinician do what they do best, that is treat the patient. So now there's a QR code on your left. Now this is an agentic AI that we have built. What is this? This is called Madhu AI. It is metabolic and diabetes health assistant. All you need to do is scan the QR. It will take you to a link. Once you go on the link, there is a button that comes Talk to Madhu. Tap on it. It takes straight to the WhatsApp. So what we have done is we have added a layer of artificial intelligence on your WhatsApp. This was built before Meta came into WhatsApp. So this is a made in India kind of for the world, and we got this validated also by our clinicians across the country. So now what this will do is once you go into your WhatsApp, you start talking to it. So this is what Madhu does. See the video that you're doing, you can continuously do it. So now it will give you a first prompt message as hi Madhu, and after that it will just help you ask a question. Now for example, this is a question that the patient has written. As a type 1 diabetic, it is important to check for your crucial health. Now see, the question is, being a type 1 diabetic for 10 years, do I have the risk of developing diabetes complications associated with diabetes? Now Madhu is going to give a health education answer to the patient. And it is going to elaborate. Now the question that being asked is that, could you elaborate on the complication more in details? And it will give a much more detailed, nuanced explanation. Allow the response to come. Yep. So you can see here, it tells the individual that you will have a risk of cardiovascular disease, the macro and the microvascular complication, the risk of developing nephropathy, the risk of developing retinopathy. So again, education being the key, education and education. Before the person turns blind and develops some macular edema, this education can actually prevent that thing from happening and reaching to the physician or the ophthalmologist with the end stage. So this is where the power of generative AI can be utilized. It's free for use. Everyone can start using it. You can ask it for your health queries or even clinical queries. It's going to be fairly accurate. To end, we know that what I'm saying at the moment sounds like a futuristic thing, but this is in existence. And as we go along, we will be finding more and more AI tools coming in to augment our practice, but we need to keep the regulations in place with accountability and transparency coming in as to how these models are working. Data privacy, the question that all will be coming to me is this data protected? Is it private? What's the legality? Blah, blah, blah. So India and global standards will be setting guidelines for it, and we will be abiding by it. So these are some of the guidelines, and the regulators across the FDA, the HIPAA, the EU Act, which is the stringent act. And India also has the DPDR, the Digital Personal Data Protection Regulation. Please go through it, as we are evolving into a country which is going to become Ayushman Digital Bharat Mission compliant. So all of us, whether we want or like or not, will have to use electronic health record, and it's all going to be integrated under interoperability. That will come under the DPDR, the Digital Personal Data Protection Regulation. Question I leave you all with is this: AI, whether you like it, want it or not, it's here, and it's here to stay, and it's here to change the way not just we practice medicine, but the way we perceive medicine. We believe all that we have been thinking and doing with evidence. It's true, the evidence is there. Evidence will always hold good. But somewhere that evidence needs a layer of data, and from there it needs information, and that data will give intelligent knowledge and information to strengthen that evidence that we have been working on. So then we won't be having this debate. A patient A HB1C, A grade of cataract surgery, korbo ki korbo na, because it will not be based on a blanket guideline. It will be based on a personalized response or a personalized best fit approach for that particular patient. So if this interests you, this is the first textbook of AI for physician. It's a good way to start. This is the QR code that you all can scan now, if you still have the QR scanner on, and it's available online in the JP publication website, and you can buy this book and start getting yourself a little familiar with the terminologies and segments of artificial intelligence. And we have gone a long way, where we have started a certificate course on artificial intelligence for physicians. Right now the first batch is on. This is a 3 months course, and the QR code on the left will get you access to apply for the next batch, which starts in June. I will invite all of you to be a part of this community which we have started called Doctors AI. It's a community for the doctors, by the doctors, just to make you literate on AI and its application. And this QR code on the left will give you access to the WhatsApp group that you all can join. And I will leave you with all this question, that healthcare or diabetes care or ophthalmology care is transitioning from just evidence-based medicine to data-driven intelligence-based medicine. The question is, as clinicians, as frontline users, do we want to be in the back seat when this change is happening, or you want to be in the forefront driving this change? Thank you very much.
Excellent talk, Amit. Fascinating. Any questions from anybody? Okay.
Otherwise, everybody's convinced.
Okay.
Captivated. Captivated.
So Amit, if AI takes over, what's the point of us being in front of it or behind it? Because we are redundant.
AI will not take over, and it's our responsibility to make sure that it does not take over.
Oh, that is not in your hand. The neural network that you showed is deep learning. Its network is more complex than the brain. If you input a Harrison in that and put a Harrison in my head, I will recall perhaps 1%, but that will recall 100%. So I'm already losing this game very fast, and I think we should. Because to our is human, we have a lot of defects, but we have to use AI 10 times more. Absolutely. And not fight with it, because we're going to lose my job. In UK, radiology is already being handed over to AI. Yes. Robotic surgery, now we are in step 1. Step 2 will be, even if your hand shakes, the surgery will stop and restart. Step 3, you just have to sit and watch. So these are the 3 robots which are coming very soon.
And I'll just tell
But I don't want to sit, the last stage.
I'll just tell this, that this is not artificial intelligence. It is augmented intelligence. Add the layer of human intelligence as the clinician, as the expert. As a domain-specific expert, there is no one that is better than you. And you are the person who is going to be the connecting point in the loop with the layer of AI to call it augmented reality. Thank you. That's going to be our job. It will be a role play change basically.
Thank you very much. Lovely session. I would invite Sudipta to.
Before we end this session, we would have Dr. Rupa Kanti Biswas's talk, treatment of DME beyond VEGF. We are waiting for this talk. So just after that, we will be felicitating all our speakers in this session. So thank you so much, Vinayakda, and all the speakers of this session. Just take your seat, and please, no one should leave without the memento. Please.
I mean, Dr. Dey, this is an excellent to interact with you, and I'm sure that we are not going to get jobless with that, but probably it is indirectly you are helping us for detecting them at the early stage, prevent complication, and make our life much easier to keep the vision stable. Probably that is also the economic part is absolutely correct.
I please request the speakers of the last session, this session, to please stay back for the moment. Just let us finish this talk.
So this is what we are going to, till now, what we have learned is about that anti-VEGF, which is actually affecting the diabetic macular edema. Yes, it does, but if you see, this is actually the situation we are having, damage to this kind of retina. So now what we are discussing about only the retinal changes. We are not discussing about the damage which has occurred to the retinal vasculature. So if we go beyond of treatment of this, if we think of repair of this retinal vasculature, then the whole disease process can actually revert back. And what we are aiming for with this newer technology. These are the all, bevacizumab, ranibizumab, aflibercept, conbercept is actually coming into the pipeline, brolucizumab. These four is already available here. Main aim is to maximize the vision, maintain the vision, so that the less frequent treatment is needed. So that's what is the main aim of the treatment for diabetic macular edema treatment. Now, even in real world scenario, or if you go back to the protocol T, so everywhere it has been seen whatever has been achieved by this 2 years time, which is slowly coming down over a period of time. So this is exactly what we don't want, because we have achieved this and we should able to maintain. So this is the combined pool data, and these are all different set of patients, but all of them are having the similar kind of gradual decline. Even in this also, now does the drying effect, we have seen with the brolucizumab, that is the maximum drying effect what we have achieved, but even with the brolucizumab also, if we go beyond 3 months, then that drying effect again going off. So then what we are thinking of, actually the disease process, we are just controlling the disease. We are not curing, or we are not reverting back the disease process. So if we can think of something which can revert back the disease process, that is actually aimed for. And even in after this is what exactly I have told you right now, that brolucizumab, again, if you have 47%, it goes down. If you try to make it of 16 weeks, then from there 24% it is coming down. So that means the drying effect is not a stable condition which is you are able to carry over a period of time. So exactly the DME is a retinal vascular disease, and treating the retinal architecture only does not serve the purpose of vascular architecture, which needs the treatment for this. So if we go to this newer drug of faricimab, then it binds with the anti-VEGF-A, which we are talking about right now. Till all anti-VEGF-A are actually responsible for the vascular permeability, but this is Ang2, angiopoietin-2 inhibition goes to the next level of promotes the vascular stability and reduces the inflammatory effect. So you got some amount of the anti-inflammatory effect by Ang2 inhibition and the vascular stability. So that's how the leakage has been actually reverted back, and we have seen near about over a period of 4 years, there is 90%, I'll show you that slide, 90% of the diabetic macular edema has been reversed back. So this is how the Ang2 inhibition, once the angiopoietin-2 receptor has been Ang2 has been blocked, so the receptors, type 2 receptors are open, angiotensin 1 works there, and it causes more of a vascular stability to be there, along with this anti-VEGF-A. So this is exactly the what is the changes, what is occurring is neovascularization, vascular leakage, inflammation, and fibrosis. So these two part is taken care by these two, but and inflammation and fibrosis, this is the only part which is being taken care by the Ang2 inhibition. And this is eosomite and rhine. This is actually a comparison between the brolucizumab and faricimab. And I'm not going into the detail of this. What I'm trying to show you here, what we have achieved here in 1 year, same has been maintained along with even in aflibercept also it is maintained over a period of 2 years. But what happens if you go beyond 2 years, that is to be noted. So if you see, yeah, so this is called the Ronex. This is the continuation. Here it is ending of the 2 years, and eosinometrine end here, and then Ronex is another 2 years to have a result of 4 years. What happened at these 4 years also, you get the similar amount of the letters gain which is maintained there, and similar amount of the macular edema reduction which is maintained beyond 4 years. And it has been seen almost near about 80% of the patient were extended up beyond 3 months. So every 3 months of if you give injection, 80% patient are stable, so you could achieve that beyond 3 years. Similarly, the absence of DME, please read this, absence of DME is achieved over 90% of the patient at the end of Ronex. So that means there was hemorrhages and hard exudate, which has actually reversed back in case of 90%. This is still yet to prove, because in our scenario, in clinical experience, we have not yet, because we just started using for the last 1 year. So we will see what happens over a 4 years of time. This is the reduction of the baseline amount of the macular edema. This is after 4 weeks. This is the clinical picture by giving only injection after 4 weeks, after 16 weeks. So there is a clinically also there is a significant, if you go for this case, you can see those dots, you can see these whitish dots are actually high reflective focus, which has been reduced over a period of time. So by giving faricimab, that indicates that there is a significant reduction of the inflammatory pathway as well. And here, post-hoc analysis also similar reduction of the, this is the analysis showing the similar reduction. Yeah. So, and even the similar kind of problem has been similar because of the inflammation has been reduced. This kind of, ERM, what we do see here, that also has been reduced in near about 52% of the cases. And that's how, with the longer durability, better maintenance of the vision, better maintenance of the foveal thickness, lowering HRF, and less ERM formation. That's what we are aiming for over a period of 4 months.
Thank you so much, Rupak. Can I have a round of applause for him? And any questions from the panelists or the audience?
No, actually, I want to ask Rupak, have you done any OCTA after faricimab to see the remodeling part of vasculature in diabetic retinopathy?
No, vasculature, it is not the macular vasculature we are talking about. Yeah. It is the macular leakage what was showing. Yeah. So ideally, we should see with the FFA, the same cases what we have shown it here. So there was only few cases which we did FFA after giving this faricimab, and there is a significant leakage reduction, macular leakage reduction.
Thank you. So with that, we come to the end of this session, the very interesting session. But it's not the end. We still have an interesting session after this. But I would like to present the memento to our physicians with us. So I request our chairpersons and doctor and speakers and moderator, Dr. Binayak Sinha, I think has received a, okay. Dr. Shomit Ghoshal, please come over for a memento. Can I have a round of applause? I think we enjoyed this session the most. Ma'am, please join. And Dr. K.K. Gangopadhyay, Dr. Amit De, Dr. Gangopadhyay, Dr. K.K. Gangopadhyay, Ashton? Okay. Dr. Amit De, Dr. Shomit, Dr. Rupak Biswas, please. You were also in this session, no? Please, can I have a round of applause, please? I'm sorry. But Aniruddha, join for this things, group photo. Can we have a small group photo with all the chairperson and the speakers? Dr. Shomit and Dr. Gangopadhyay. Hey, the Dr. Gangopadhyay, please, for the memento. No. Dr. Amit, stay back, stay back. Thank you so much. I would request these chairpersons to please stay back to give the mementos to our panelists who have been staying over. And the chairpersons of the next session, Dr. Mohammad Yasin sir and Dr. Shamul Pandey, please come over to the chair. Dr. Shubhashish Nag sir, please come over to collect your memento, sir. Please. Sir, Dr. Abhijit Ghosh, Dr. Vinayak Sinha, please hand over the memento. Dr. Vivek Datto, Dr. Shondip Mitro, Dr. Somdat Prasad, Dr. Molay Sarkar, Dr. Molay Sarkar, Dr. Shondip Mitro, Dr. Vivek Datto. Can I have a round of applause for they have been throughout there and they are still going to be there in another session. Dr. Somdat Prasad, Dr. Arup Bhomik, Dr. Arup Bhomik, please. Dr. Oyan Mahanto, Oyanda, Dr. Oyan Mahanto, Dr. Vipin Rana, please come. Dr. Debashish Boiragi. Hey, Oyan Oyanda, chao. Dr. Shibashish Das. Dr. Debashish Boiragi, please. না তুমি এখানটা এসো ও খুব বেশি তাড়াতাড়ি না আমি ডাকছি আর কি একে একে আসো ডক্টর রানা ও ডক্টর সোমদাত প্রসাদ বাকি আছে বোধহয় ডক্টর বিপিন রানা এটা কার বিপিন রানা থ্যাংক ইউ ক্যান আই হ্যাভ সাম রাউন্ড অফ অ্যাপ্লজ ফ্রম দ্য ইয়াংস্টার্স Dr. Somdat Prasad, Dr. Oyan Mahanto, Nana, ওদেরকে বলছি তোমাকে নয় ওদের বলছি দিতে চলে এসো Please stay over, we have another session which is a case presentation session which would be very interesting with dilemmas. Thank you. And we move over to our next session, which is a very interesting session of case presentation. And we start with none other than Dr. Shugato Paul. To moderate the session, I request Dr. K.K. Roy.
So we come at the end part of the session. So we have a case presentation by Paul sir. What will I do?
So good afternoon and thank you OSWB. So this is basically an interaction session. So panelist, Arup, তোকে জিজ্ঞেস করবো সবার আগে কি করব হ্যাঁ সো বি কেয়ারফুল কথা বলিস না হ্যাঁ সো জাস্ট কনসেন্ট্রেট অন দ্য ফ্যাক্ট দ্যাট লেফট আই 636 পয়েন্টার N18 grade 4 brown cataract and fundus very hazy view maybe some edema and this is the sort of fundus picture you can see. There is little bit of maybe exudate here. So, opinion from the cataract surgeons here. What should I do? Yes, Vipin. No, moja korish na boss. Yeah. OCT, very dense cataract, OCT was done and this was the OCT. Mike.
Go with the cataract surgery plus Ozodex.
Okay, so here, yeah, Arubda with IVTA. So the view was very hazy and probably there was some exudates there but central looks okay. I went ahead with cataract surgery without any adjuvant. Vision 4 weeks was 6/6 partial. There was some macroaneurysm around the thing. OCT was done at 4 weeks and this was the OCT. Center was still clear so I didn't do anything but there is 10% chance I believe of non-center involving macular edema becoming central involving after 3 months of cataract surgery. But here I didn't use anything else, just went ahead with the cataract surgery. Na pathaini. Nah. So this is the next case. 64-year, this is my last case, so Sudipta don't get tense. 64-year male, vision 636, NS2 cataract, diabetes good control, and came for cataract surgery. What shall I do? Reduce the edema. Vipin?
Sir, in such cases, what I prefer is I just go for the cataract surgery with the Ozurdex and they do absolutely fine. And as you mentioned, the last case, we give the Nepafinac for 3 months.
Okay, Dada, Vivekda was.
Anti-VEGF, and after a week, I'll go for the phaco surgery.
So even if the edema is still there, you will go ahead with cataract surgery?
Yeah.
Rupak,
After
your
giving the
opinion in this case? Ki?
আগে ইনজেকশন দুটো দাও তারপরে দেখি
দুটো দাদা বলেছে একটা
যাই হোক
আচ্ছা this
retina
patient,
specialist not
this-
you
this
retina
patient
specialist.
came to me for cataract surgery. Now if I just add the patient elsewhere had already a razumab
এইসব
on
বলতে হবে তো ভাই
10/9/22 and a Paginax on 9/12/22 and the patient came to me on January as I said on January, so patient already had 2 injections. So
January 2025
23.
or 23.
So what shall I do?
No, cataract surgery with Ozurdex can be an option.
Okay, so that is one idea. Rupak?
Ideally, still the cataract is not significant enough that you should do the cataract surgery right now. Stabilizing the macula is the primary importance. So either that, I need to see the fundus exactly, not with the OCT, and see whether it is a microaneurysm is there or not. So treat it accordingly, either with anti-VEGF or steroid. I will prefer here the steroid and laser if needed, followed by cataract surgery to you later.
So very important take-home message from Rupak, because the cataract is not significant, treat the macular edema. So I did 2 injections on 27 January and 28th February. Vision from 636p was 624. The edema is slightly reduced now. Rupak, again your advice, the edema is reduced slightly but still there. 1 razumab, 1 Paginax elsewhere and 2 Eylea in monthly interval. So shall I give the 3rd injection or go ahead with the cataract surgery? Cataract has gone worse. So I planned for cataract surgery along with Ozurdex, but as you know, it's not covered. 2 injections procedure is not covered in the Mediclaim. So I went ahead and gave IVTA along with the cataract surgery. Vision improved to 6/9 on 31st of March. Operation was done on 28th of March. And after 4 weeks, this was the OCT, and vision improved to 6/6 part. Now, after 4 months, again there was recurrence. Now, shall I give Eylea or anything else? I gave Eylea actually, again along with IVTA. I don't know why, but at that time I gave Eylea with IVTA. The edema came down probably because the cataract surgery IVTA helped to reduce the edema. I combined it with IVTA, just 2 more slides. Okay, time is over. 2 more slides. And the vision actually maintained to 6/6 part till November 2023, when the edema recurred again, and I gave another Eylea, and came back again in May 2024. Rupak, at this stage, what shall we do? Mike.
From this hard exudate, which is close to the fovea, which is looking like there is leaking, some microaneurysm is there. So if you can treat them with the focal laser, probably the recurrence of those cystic changes will go back.
Okay, so laser and observation. So at this stage, because the patient is very sensitive to his vision, I gave again Eylea, which was free available, and I did the focal laser. Rupak, I did the focal laser along with Eylea, which was available for free. So that was the thing on May 2024, and this is how the patient is in December 2024. The laser worked well and no further injection required in December, and patient is due to come back in April 2025. Thank you. And we invite everyone to the midterm conference at Sinclair Chalsa. There will be, just forget about the academic sessions. I hope Sudipta is not here. Forget about the academic session. There will be jungle safari and Sunday picnic at Gurumalar Jungle Resort. Please join us for the midterm conference.
Thank you, sir.
Thank you.
I think
নাম 4 মিনিট হয়ে গেছে তো
গরুমারা, yeah.
So,
ইনজেকশন দিচ্ছে বলেই যাচ্ছে ইনজেকশন দিচ্ছে
এটা রিভেঞ্জ.
So, from the last presentation, we have two take-home message. If we have a no media is not clear, we cannot see the fundus. Straight away we go for cataract surgery, followed by fundus examination and management. And if we have a good fundus view, we can manage the diabetic retinopathy part, and then we go for cataract surgery. I have one question, sir. So, if during cataract surgery, due to pressure fluctuation inside the eye, so there is a chance of PVD induction. And that may cause bleeding in case of PDR. If it is a fundus is not visualized, suppose very dense cataract, and you are suspecting this may be case of PDR. So when you are doing cataract surgery, do you going to change any parameters in your phaco settings or
You
to
can
prevent
do
the
if you-
PVD induction?
So that possibility what you have described is yes, theoretically that possible, but again, in very rare situation, we do see that much of significant proliferation which PVD has caused bleeding. Technically, that chance is very less, but if you are really, scared about that one-eyed patient, something like that, you can add up of anti-VEGF maybe 2 weeks before that so that the vascularization regresses. So that is another way of preventing it.
Okay, sir. Thank you. We can go for our next presentation by Dr. Anujit. Bilateral retinal vein occlusion, where is the culprit?
Thank you so much, sir. Thank you, OSW, and thank you, CSC madam, for the talk. After a lot of diabetes and cataract surgery, we are all very hypoglycemic. So I'll just quickly go through this case that I encountered, and we can discuss some possibilities about the cause. So a 60-year-old female presented with bilateral retinal vein occlusion. She was a diabetic as well as a hypertensive for 5 years, and she had a sudden drop of vision. Her right eye vision, where the retinal vein occlusion had CME as well in the macula, was 636, while in the better eye she did not have as much CME, but she had slight amount of macular edema. She was also a relative of a patient of mine. So initially we start with treating the retina as we usually do, and after intravitreal ranibizumab, after a month, the edema had resolved, not so much in the right eye as much as in the, not so much in the right eye as much as in the left eye. So now we go to the actual conundrum of the case. So on further evaluation, when we see a patient retinal vein occlusion, we always think of systemic, especially when it is bilateral. So we thought of diabetes, hypertension, and the entire gamut, but till here, everything seemed to be perfectly normal. Here is where I had a doubt, and I asked the patient that if you are having bilateral vein occlusion, and if you are not having any significant coagulopathy, and if your hypertension is also under control and your diabetes is under control, then why is this happening to you? You should not be having something like this. So then, just out of a completion's sake, I referred the patient to a cardiologist. An ECG was done and a right bundle branch block was found. That is also not treated very significantly by cardiologists as well. An echo showed an adequate left ventricular function with some amount of concentric LVH. That is again something which is structural. But then the cardiologist advised a 24-hour halter. So that showed some amount of arrhythmia, some amount of tachyarrhythmia, some amount of bradyarrhythmia, and some intervals of isolated ectopics with intermittent sinus bradycardia. What was interesting to note that there was some intermittent sinus pauses of 4.11 seconds. So according to the criteria, if the sinus pause is more than 6 seconds, it is an indication for implanting a permanent pacemaker. So over here, as ophthalmologists, we are thinking at the level of the retina, we are thinking of systemic factors, we are thinking of diabetes and hypertension. But what if the problem is somewhere else beyond these systemic factors? What if it is something to do with thrombosis and atherosclerosis? But what if it is something to do with the electrophysiological activity of the heart? So let's just discuss what the existing literature says. If we compare retinal vein occlusions as well as atherosclerosis, there is a higher incidence of acute myocardial infarction in patients that present with retinal vein occlusions. And majority of these patients are also hypertensive, diabetic, with dyslipidemia, whether controlled or uncontrolled. What about discussion about bilateral RVO as well as electrical activity of the heart? So if you search the literature on bilateral RVO, we usually think of coagulopathy and hypertension, but there are some isolated incidents of thrombosis presenting in cases of SARS, in cases of COVID, in cases of some sort of drug mutation, etc., etc. But there is, as we all know, some amount of link to atrial fibrillation as well. So there is a link of RVO to electrical activity. And so coming back to the patient, this is all that happened to the patient in the 1 month while the patient was recovering from the anti-VEGF injection that I gave her. And when she came back to me, she told me that the cardiologist had advised her to go for a permanent pacemaker. She was kept on strict hypertension monitoring and hypertensive medication, and she may or may not need further anti-VEGF injection depending on how the RVO progresses or goes down. So the take-home message over here is simply that there is something else that we need to look for in our patients who are already diabetic or hypertensive. Most likely the cause should have been coagulopathy or hypertension, systemic cause being diabetes, but underlying ischemia needs a workup, and it is prudent to also think of these kind of diseases. For this patient in particular, she had to undergo a pacemaker implantation, an RVO, which many people for the left eye would observe and for the right eye would inject and ask the patient just to keep the parameters in control. We found something that needed early intervention and prompt intervention, and it was a criteria for permanent pacemaker implantation. So just a take-home message, look beyond these two factors as well.
Thank you, Anujit. I have one question. How frequently you got bilateral vein occlusion?
So bilateral vein occlusion is not that uncommon, but sometimes we are usually asked to look beyond at systemic causes, and usually we stop at coagulopathy and hypertension as well. This is where I would like to ask the panel and my esteemed colleagues that how often they are seeing it.
The first question is that whenever it is any disease is bilateral affecting both eyes, so we need to think beyond eye. So this is the dictum. Now, this patient, if we think of anything related to the cardiology or heart related, first degree heart block, that is a cardiologist's decision whether the pacemaker is needed or not. Now for first degree heart block, that much of arrhythmia is very difficult to cause bilateral, number one. Number two, the patient itself is hypertensive and diabetes, though under control, and dyslipidemia was probably also there. These three factors is sufficient enough to cause bilateral things. Along with that, probably I will do serum homocysteine level also to rule out for them, though patient is little older to have those things. But again, those reports what you have shown is mainly the case reports. So it is very if we get, for general ophthalmologists also to understand, if we get a clot in the heart, if it gets dislodged from there, it will cause more of a BRAO or CRAO rather than BRVO or CRVO, because that is a clot. The venous part is completely different. So venous occlusion occurs only with atherosclerotic or thrombosis. It is not by the embolism. Embolism occurs due to the cardiac or ophthalmic artery or a plaque which is dislodged and gone and sit there. So definitely I would look into this thing, but again, another cause of hypercoagulability will be looked after first.
Yes, sir. Very difficult for the clot to travel through the arterial system, capillaries, and then to the venous system and cause a clot.
Another question to Devasi Bariki sir. If you got a simple vein occlusion, so what are the investigation you do normally in day-to-day practice?
So I always go for lipid profile apart from blood pressure and blood sugar, and in young individual serum homocysteine level that I always ask for. These are the basic things.
Sir, anything else?
In my life, I have not seen the bilateral occlusion. I almost.
Yes. Thank you. Okay, Anujit, we can, thank you. We can go for our next talk by Dr. Deepa Saha, Trouble with Soft and Cheesy.
So, thank you Sudipta Di and OSWB for making part of this unique program with the diabetologist. So, my presentation is slightly different. It's a little bit surgical oriented, bread and butter. The topic is trouble with the soft and cheesy cataract in diabetes. Now, we all know that there are a lot of complications with the diabetes. along with the retinopathy, we should also look for the cataract and the various types of cataract you can see we find in the diabetes. Studies show that it's 4 times more prevalent of cataract in diabetic than the normal person. Incidence, so I have a diabetic center. I saw that 45 to 54 and within 60 years see more cataract, those who are suffering for more than 10, 15 and 20 years for the diabetes. The main risk factor as the longer the duration of diabetes and the poor metabolic control. So I have a very short clips of 2 videos. So this is one very soft cataract, 46 years old diabetic. Now you see for these cases, so very difficult to chop and these things, I prefer to do a hydro in one pole so that one pole is in the bag and one pole in the AC, and then with epinuclear mode, you can complete very easily. This is my, sorry, this is, this is second case, 55 years old male diabetic. Though it looks very soft, but this type of cheesy crumble type of cataract is very difficult to hold, to chop, to separate the pieces. After doing this main incision, hydrodissection, you see, I tried a central trench, tried to chop, but whenever I try to hold, it getting loosened. So I prefer to do a long groove in the middle. The best way is to separate it into 2 pieces. That is really sometimes very, very hard. Try it for a long time from various side ports, main port, but getting very difficult to soft and separate this cheesy, crumbly cataract. But later, anyhow, I separated it, tried to do the chop. This was I doing in a topical anesthesia, but what happened, the time is so long, I have to put some xylocaine in the inferior fornix so that my surgery get prolonged, and the patient was very restless. But anyhow, so manage this crumbly cataract, taking long time. So my take home is, get your eyes checked, rule out not only for retinopathy, but also for the early cataract, and manage early so that you can get a good vision. Thank you so much.
Thank you, ma'am. So in your first case, which lens you have implanted? It was a multifocal lens?
Yeah, it was a multifocal lens.
Is there any consensus in diabetic patient putting multifocal lens? Means patient till now doesn't develop diabetic retinopathy. In that case?
I usually avoid. I usually avoid.
You can avoid, but there is no contraindication for implanting a multifocal lens in case of diabetic if patient does not have any diabetic retinopathy.
Another
There are a lot of patients 40 years diabetic not develop diabetic retinopathy.
Sir, another question. If diabetic patient after doing cataract surgery, are you prescribing nefapanac in all the cases? Or
I routinely prescribe nefapanac in all cases, whether it's a diabetic or not diabetic.
Not for diabetes.
Yeah. All cataract patients.
Before surgery?
Yeah. I would like to start nifapinac 1 week before cataract surgery.
For a non-diabetic patient, you
No.
are putting after surgery also.
After surgery, I continue with nifapinac and I stop steroid after 2 weeks and continue with nifapinac for 1 month.
But sir, most of the cases it has been found that the pseudophakic, DME, it comes after 6 weeks and that. So it's better to continue nepafenac for more than 6 weeks after cataract
You are
surgery.
talking about diabetic retinopathy or
No,
CME?
CME.
CME.
In diabetic patients after surgery.
If there is no retinopathy and surgery is uneventful, there is no need. But if you have some kind of retinopathy, no edema, you have to continue for 3 months.
And there is one study, ma'am, in which it has been observed that the chances of the pseudophakic CME in the cases like where there's a rent or there's a diabetic retinopathy, the nebafenib when given for the 3 months post-operatively, it reduces the risk of pseudophakic CME. So the same goes for the diabetic retinopathy and in other cases also where you have a rent or where you have chances of the like uveitis cases. Thank you.
Thank you, ma'am.
Thank you so
we
much.
go for our last case, the diabetic cataract, easy way to go, by Dr. Priyanka Chatterjee.
Good afternoon. I come here on behalf of all the junior practicing ophthalmic surgeons like myself and a lot of my friends who are basically anterior segments surgeons but are routinely treating diabetic macular edema in their practices. And Arup sir, I would just like to say that even though you said that just push all your patients to a retina specialist, in practice it is not happening. We are not doing it. Shugato sir is not going to do it. And I see a lot of prescriptions in my 2.5 years of private practice. I've seen a lot of people treating retina, even though they are trained anterior segment surgeons. So I feel like we must open up and anterior segments must be allowed to come and speak about their experiences in front of seniors. We get very scared, we get intimidated. Retina people talk a lot of trials, protocols, this, that, and we get scared, but we may just need to know the basics. If diabetologists are today picking up diabetic retinopathy in their clinic, then they're going to shift it to the ophthalmologist. The general ophthalmologist should be able to manage basic DME so that the tough cases we send to the VR specialist. I feel like that's the way to go. I am very junior, but this is just my personal opinion. So I did a lot of literature review over the last 2 weeks, tried to gain some data on what I'm going to talk about. Please, sirs, correct me if anything I say wrong. So basically diabetic cataract or management of a cataract with DME will start with what the patient wants at that point of time. Does the patient have visual complaints or has moderate visual complaints or has severe visual complaints? And mind you, none of this is related to your clinical findings in any way. What the patient believes is different from what his findings are. So the timing for cataract surgery, I went through a lot of literature. And what I realized is the timing is now. Whether it's a cortical cataract, an NS2 cataract, or a grade 4 hard brown cataract where you can't see the fundus, the best time to operate a diabetic cataract is now. A few reasons will be your sugar control may be lost later on in future. This might be your last bus. I have had 2 patients where they delayed the cataract. Now it's been a year since they're trying to control their sugars. It is not happening. Cataract will limit visibility of your retina at any given point of time. Treatment will become difficult. And more difficult cataract extraction will always lead to more inflammation, which is driving edema. So, in my opinion, the best time is now. I might have personal financial interests in that. Considerations before cataract surgery. Few things that I came across which I didn't know. Intracameral phenylephrine, they are saying, is reducing post-op CME. There is a few studies. And always watch for NVIs in your post-op period, even as much as 3 months. Patients who had no florid diabetic retinopathy before you operate the cataract, suddenly in the course of 3 months, do come up and present with NVIs. The percentage is quite high, around 9% in that study, if I may be correct. So clinical examination subsequently after any cataract with retinopathy should be careful. You might want to follow up the patient after 3 months again. When to inject? Along with the cataract surgery could be the best time for many logistic reasons for the patient's benefit, and even data-wise what they are saying is it may not be a bad idea. When I checked, CMT changes, central macular thickness, after a cataract surgery in a non-diabetic patient is similar to that in a diabetic patient who have no DR, around 10 microns. CMT changes in a post-cataract surgery in a diabetic patient with retinopathy, it's going up to 100 microns. But if you're injecting along with surgery in the same sitting, at 3 months, it's coming to around 10 microns, which is similar to a no DR state. So there is no need to delay or pre-push your injections. You can do it in the same sitting, very convenient for most patients. Are all injections same? Like all IOLs, whether a 10,000 package and 80,000 package, does it all result in same with different brands? No. This is what I learned. Protocol T says that basically in common man's language, the more costlier injections are giving better results in DME when compared to the non-costlier injections. Dexamethasone versus anti-VEGF. The mean BCVA after a certain point of time is coming to the same thing. The number of injections is around 1/3 what is required. Cost, if you see the equivalence in our purchase price, almost comes up to the same thing. But what changes is patient convenience. If the patient can't come for monthly injections, 3 monthly injections or even longer may be a good fit. IOP rise, they are saying, is up to 25% patients are experiencing, but on repeated injections. On injection 1 or 2, it is less. More than that, there may be an IOP rise. So that is one thing that we must consider. These are a few cases I would just like to know from the audience, preferably the anterior segment surgeons. Maybe what is the plan? Severe diabetic retinopathy, a cortical cataract with a cyst in the... So what if I do the cataract with the injection?
Cataract is not very advanced. And one thing, if you want to do the cataract, patient have a insurance. If you do
Yes,
the two procedures at the same time, you will patient
Correct.
will be.
But then within 1 month, I think they will not agree. So you have to wait for another month before you can do the next procedure.
No, you can do even 7 days. No issue.
Okay.
Okay.
So what should we do in such cases?
Better to, I'll refer to this patient to Sugata for retinal injection, and I hope Sugata will refer send me back this patient.
Sir, are you going to refer back? So what I did was combined surgery, cataract with injections. But I feel in this case, an Ozurdex implant would work better because of that cyst which is in the ONL layer. Certain things that I also found out, OCTs might have some biomarkers. This is a little complex, but one must go through it to see which OCT changes says what. Some describe ischemia, some cysts may describe poor prognosis. One thing we must always remember is the cystic macular edema on an OCT is not directly correlating with vision in any way. So poor visual prognosis can happen in many other situations. So this is a little this thing. This is another case example. This is the patient came first to KKR and vision is 624, grade 2 cataract with few microaneurysms. This is how the OCT looked. I think he advised the focal laser. Patient lost to follow up, comes back after 1 year. This time he comes to me. Now the vision is 2/60 with the same grade of cataract, and this is how the OCT image looks. The cyst has now coagulated to become a big large cyst. So what should we do? What should be the plan of action?
In the first place, the first OCT, will laser be the option? I don't think so, because it's center involving macular edema.
First case.
No, the first one. First OCT is.
I'm not sure whether
Just go
injection
back.
was advised by him along with the focal laser. I'm not sure about
Just
that.
go back. Krishna is there.
He won't remember the case.
But
Yes, sir,
I
I'm
need the
sorry,
fundus image first.
Yes.
But one thing, if it is also
There were just
center is
few
involved,
microaneurysms.
if it is I feel it is a leaking image there, just away from phobia, I prefer to do focal laser. Sometimes along with anti-VEGF, but if it is patient is not affording, in that case only laser. So because only focal laser, that can decrease the this edema. Obviously anti-VEGF will help, but it's actually lot of costs are involved. That's why if I have a chance to do focal laser, I always first to do laser along with injection.
Just to clear the confusion for the general ophthalmologist, there are two types of leakage in diabetic macular edema. One is vascular leakage, which is like a diffuse. একটা যদি পাইপলাইনের মতো থাকে যার গায়ে খুব ছোট 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 ফুটো হয়ে গেছে অনেকগুলো, ইজ লাইক এ সিভ, তো সেখান থেকে জল চুইয়ে চুইয়ে পড়ছে। আর একটা হচ্ছে যেখানে একটা বড় ফুটো হচ্ছে যেখান থেকে জোরে জল বেরিয়ে আসছে পাইপলাইন দিয়ে। সো ইউ ক্যান পুট এমসিল ইনটু দ্যাট হোল যেখান থেকে জোরে জল বেরিয়ে আসছে। বাট হোয়েন এভার ইউ হ্যাভ লাইক দিস কাইন্ড অফ মাল্টিপল সিভ লাইক, so that vascular leakage can only be controlled by anti-VEGF and that microaneurysm to be treated with the focal laser. So just an analogy to understand it. Now it is not that in DME only it will be only the vascular leakage or only it will be, majority of them are a combination of that. That has to be judged by seeing the fundus examination or if needed by guidance of the fluorescein angiography. And then you can decide accordingly for the treatment.
Right.
One thing I want to add, if a posterior pole is a lot of hard exudations there, probably there is some leaking is going on. In that case, we should go for angiography to see the leaking is there or not, or focal laser.
Correct.
It will actually help us because compared to injection, for laser is less costlier, and recurrence also, number of recurrent treatment also less.
So this is what I did. I removed the cataract, and post 2 weeks of Ozurdex, this is how the picture looks. I'm waiting for the patient to go into the second month and then decide what has to be done. So this is another case where after 1 month of Ozurdex with cataract, this is the picture, and vision is 6/18 from 2/60, but the hard exudates are now at the fovea, which will take time to clear up. Sorry. Okay. So these are my last 2 cases. Not all diabetic patients should be managed by us. We must know when to refer out immediately, and PDR is definitely one such case where you must always refer out. Also, if you see macular traction on OCT, it's best to refer out such patients. Thank you.
Thank you, Dr. Priyanka.
Big round of applause for all the speakers, the moderator, and the chairperson of this session. Thank you so much for your patience. And I would request our chairpersons, Dr. Mohammad Yasin sir and Dr. Shamul Pandey sir, to hand over the memento to the moderator and the speakers of this session. Please. Speakers. Dr. Shugato Pal, Dr. Onujit, Dr. Deepa, Dr. Priyanksha, and Dr. Please, তুমি আগে যাও, moderator তো তুমি যাও. Sir, please join, একসাথেই দিন. Please, can I have a round of applause? Please, Shugato. Oh, acha, Dr. Onujit, okay. Who's that? Shugato, যাও. আরে যাও, তোমার নাম এসে গেছে. Okay. So nice to see the juniors come up. Okay, Priyanksha, come. Next. Priyanksha. Shugato পরে নাচতে যাবে. জুনিয়ররা যাবে আগে. ওই তো সুগত বলেছে আগে এই যে তারপর দীপা কাম দীপা হাততালি মানে সুগত wants that we should have the loudest applause for Shugato Paul for taking 4 extra minutes. Okay, come on. আমি একটু দাঁড়াই, হ্যাঁ একটা ছবি তুলে ফেলুন. অরূপদা কোথায় গেল? ডক্টর অরূপ always. And we should not forget that we could finish this. Okay, sir, please, I would request Dr. Kajol Prasad Ghosh and Dr. Shubhashish Nag and Dr. Arup Chakraborty to please join to felicitate our chairpersons, Dr. Shamul Pandey and Dr. Mohammad Yasin, sir. Arup Chakraborty, sir, please come on stage. The speakers of this session, please stay back for a photograph. Shugato lost. Oh, he ran away. Finally. Shugato. To Dr. Shamul Pandey. Thank you, sir, for taking all the trouble. Sir, ekটু ওদিকে sir, নামটা দেখা যাচ্ছে না. And now, without whom we could not finish our session within time, are the chronographers, Dr. Shagnik Shurjo Das. Timekeeping is very important, along with Dr. Anujit and Dr. Tulika Ghoshal in the lead. Can we have a round of applause for all of them? Tulika Di and Anujit, please join on stage for this, for a photograph, and the speakers also, please come over. Where is my coordinator, Dr. Arup Bhomik? Arup dake ekটু দেখে দাও না. এই moderator ভাই তুমি তো এসো. আরে একটা ছবি ওদের সাথে তোলো, ওদের জন্য রূপক. Please come.
There is one award left.
কাউকে ঢেকে দিলাম. এই তুমি সামনে.
Shudipta, there is one award left. We couldn't have done any of this program without our chairperson scientific committee. So, Arupta requesting you to give the memento to Shudipta.
No, actually, this session was a bit difficult because it was collaborating between two associations. So, two persons who stood rock solid next to me. I wanted to tell that to Dr. Arup Bhomik sir also. It was Dr. Arup Chakraborty sir and Dr. Arup Bhomik sir. Both of them were stood rock.
না না খুব ভালো অর্গানাইজ করেছে
Now I would like to give a vote of thanks to all of you who have spared your Sunday morning here for this session and made this session a real success. Loud applause. Who? কার বাকি আছে? এগুলো তখন দেয়া হয়নি? এ কি? Dr. Arup Chakraborty sir. Shobai, please join hands to Dr. K.P. Ghosh sir, who's always there to encourage us. Dr. Pushpita Shah left. Didi ke aage daka hoka, ekta chobi dorkar. Shibashish ke dekechi, he left, ami dekechhilam. Ke?
Swayam.
Dr. Swayambhu Prasad Ghosh is there. I called him. Left. Anyway, before Kolpita also came, all of them they left. I called them. Shondip Mitra. Hey, to Rudro! Come to collect the memento. Rudra's coming here for the lunch and the memento. No! Come. Please, Swayambhu, join. Yeah, but you didn't come up when I called you. I called both of you.
এই তো
You should show this. This memento was specially found out by Mr. Shotyajit because I wanted something which was different. So this is made of wood, small bits of wood making this. আর কি বাকি আছে?
উনি আসেনি
না, he didn't come.
না তো সিঙ্গাপুরে আটকে আছে
পুষ্পিতা দি কি বাইরে আছে
ম্যাডাম বেরিয়ে গেছে
Okay. Anybody else left? অরূপ ভৌমিক তো দেয়া হয়েছিল, তারপরে কি হারিয়ে গেল? অরূপ দাকে ডাকা হয়েছিল, অরূপ দাকে দেয়া হয়েছিল। Anyway, before we part, let me please thank all the sponsors, Ajanta Pharma, Dr. Shotyajit, Mr. Shotyajit, Roche, Intus, and Lupin for helping us make this session and this CME a success. Thank you so much. Big loud applause for all of them. And of course, the seniors of OSWB, the juniors of OSWB and my friends, thank you so much. Our office staff, Apurbo, Shudhanik and Prashanto for the small things which made this such beautiful. Thank you, all of you. And please don't forget to join us on 9th of March for the Glaucoma Conclave during the Glaucoma Awareness Week of OSWB. This program is of Ophthalmic Society of West Bengal celebrating the Glaucoma Awareness Week. 9th March at Shabumi. Thank you so much and have a great day ahead.